Recording in progress.
This time. Okay. Good afternoon, honorable members. Good afternoon to the staff. I'm joining you in another place where I've just come out in a meeting where I was presenting here in Pretoria, University of Pretoria. But we can start with our meeting. Can we just start with a moment of silence and then and meditation? Thank you very much. At least now that you know you're not having a robot chair, I may switch off until I get into another nice place where I could then put together. I've just come out of the meeting now. I'll switch off my video. Thank you very much, honorable members. We have 4 presentations that we need to get into today. But before we start, I would like us to get to know from Ms. Machalamba, the members who have logged in for this meeting.
Good afternoon and thank you, Chair. Present is Dr. Dlomo, Ms. Klego, Ms. Shabangu, Ms. Kumalo, Dr. Leroux, Stefan Staden, and Mr. Zungula. I've received an apology from Ms. Clark and Mr. Mjadu. Thank you, Chair.
Okay, thank you very much, honorable members, for your logging in. I do have a challenge that there were some presentations that were sent in quite late yesterday, but this one that we are starting with was received well on time. We had a lot of time to go through it. There has been an apology that we received of one, not an apology, just withdrawn. A person was supposed to present, has now withdrawn. We have been discussing with Ms. Machalamba whether we could bring the 4th, which would have been a 5th presentation to that slot at 6 o'clock. But those who are presenters who are presenting said they will have a challenge to bring their presentation early on at 6 o'clock. So we'll have our meeting having an adjournment at 6, and we'll come back at 7 as Ms. Machalamba can now show us the agenda. Can you just fly the agenda, Ms. Machalamba? Ms. Honorable members, there is the program. So in our program, it reflects that we will take a break at at 6 and be back at 7 because of this challenge that I've just raised with you. I want the radio. Hello. Can I therefore request the first presenter
That's
to
me.
start now? And hold on, you have 30 minutes to make a presentation to us.
Yeah.
Honorable members will engage with your presentation, and then you'll come back again to respond to the questions asked.
Yes.
We will take it that we have seen your presentation, so we are not going to go word for word. We have read your presentation, which came to us. We will be very thin on the responses because of the time that we still have to do much more. But your 30 minutes starts now
Okay.
at 3:05, and the 25 to 4 would have done with your formal presentation. Thank you very much. Thanks.
All right. Thank you. Thank you.
Introduce your team. Thanks.
Okay. Let me share my screen. Right. Can everybody see that? Good. Okay. So, first of all, hang on, that's not working. There we go. Excuse me, somebody's ringing me. Sorry. I can't, I'm sorry. I'm really sorry. Sorry. Right. Yes. So my name is Clive Bates. I'm a consultant in sustainability and public health, former civil servant, former director of Action on Smoking and Health, which is where I got interested in this issue. That's the main anti-smoking organisation in the UK. I do not have conflicts of interest, and I should disclose this, supported tobacco harm reduction as a public health strategy for more than 25 years. I am going to draw out 6 points for you to consider. And then at the end, I'm going to come back to some of the issues that I think they are with the bill in front of you. And this is the sort of narrative that we build up for tobacco harm reduction. Smoking is still the problem. People will continue to use nicotine. Smoke-free products are much safer. These alternatives, the new alternatives, are displacing smoking, not adding to it. Young people will ultimately be the end of smoking and the cigarette trade, and policy is dominated by unintended consequences. Okay, and that's something, so we're going to get more into the meat as we go on. Right, let me move on. Okay, first thing to say is that smoking is still overwhelming the problem. Worldwide, around 800 million people die annually. That's roughly similar to the number of people who died annually 2020 and 2021 from COVID. So it's a comparable scale of premature mortality along with COVID. But of course, it goes on every year, not just during the period of that epidemic. The global burden of disease study showed that for men, at least, tobacco caused the greatest amount of loss of life, and we'll see why it's men and not necessarily women shortly. But it's a major killer. Smoking prevalence data we have from I'm going to use the World Health Organization data. Comes in these difficult to read tables, so I've just extracted the relevant data. Typically, smoking globally is at around nearly 17% and around nearly 8% in the Afro region. These are the numbers for South Africa. 35% of men, almost 21% of both sexes, and 6.5% of women. So South Africa well above the global and African average here. That's Africa, that's the Afro region. So it's not including North Africa, which also has high levels of smoking. But that is a lot of smoking there, 35% amongst men, if that's correct. I think that number is based on the GATS survey. Okay, this is the sort of league table of the Afro countries. In green, that's South Africa there, compared to other African countries. The red is the average for the WHO Afro region, and the light blue is the global number. So you can see South Africa, along with Mauritius and Lesotho, very high levels of smoking in South Africa. Okay, just back to globals. I think South Africa is always globally significant in terms of what it does and what it thinks, as it makes a difference internationally. Generally, we have seen smoking prevalence trend down, but at the same time, population has trended upwards. So the proportion of people who smoke has gone down, but the number of people who smoke has gone up. And again, the Global Burden of Disease study shows a gradual drifting upwards of the number of people who smoke in the world, despite progress in reducing smoking prevalence. So we do have an ongoing problem with smoking that consists of well over 1 billion people. It's largely dominated by men who smoke, far more men, roughly 5 to 6 times as many men smoke as women worldwide. And that's why it's a bigger killer of men than women. Second proposition I want to put to you is that whether we like it or not, and we may not like it at all, but people will continue to use nicotine. Okay. Now I'm going to draw here on a slide produced by what I would say is the world's expert on nicotine. It's completely independent, University of California, San Francisco, Professor Neil Benovitz. He listed what he calls benefits of nicotine use. And I just want you to look at this list that he put up here. Remember, this is perhaps the most credible academic in the world on nicotine use. Pleasure, stimulation, cognitive enhancement, relaxation, mood modulation, psychiatric benefit, enhanced athletic performance, and weight control. So the way I look at that list, I think, well, these are the reasons why, even if I don't like it, these are the reasons why people use nicotine and are likely to continue to use nicotine, even if it's dependence forming or it harms them in some way. Okay. Now, he does point out that some of that may be down to the effects of withdrawal and craving. Okay. There are other studies on this that show why people who uses nicotine use, not really to do with the products. It's to do with characteristics of the individual and their circumstances. And this is a study from Wellman, where he lists 98 conceptually different potential predictors for nicotine use in 53 studies. So I think when we're addressing nicotine, we have to think of it like a sort of recreational psychoactive substance that is legal in general in society, like caffeine, like alcohol, increasingly like cannabinoids. And we need to think about regulating it in a way that does the minimum possible harm amongst those people who choose to use it. Okay, so I don't think it's something that can just be eliminated in the same way that it would be a fool's errand to try to eliminate alcohol or eliminate cannabis use or not that people haven't tried, or caffeine. It needs to be seen as something that needs to be managed in society rather than just wished away. Okay, third proposition of my 6 that I want to put to you: smoke-free products are much safer. We could go into this in enormous detail, but let's just get to the fundamentals. People smoke for the nicotine but die from the tar. And this is a famous quote from Mike Russell from 1976. What we know is that nicotine itself, while dependence forming or in some circumstances addictive, isn't the primary cause of smoking related disease. Far from it. It has some marginal effects, may affect the cardiovascular system, may affect pregnancy outcomes and so on, but it's nothing like the main driver of disease caused by smoking. Okay, that comes from the tar, which is the particulate matter and the hot toxic gases that arise from setting fire to organic tobacco at 800 degrees centigrade in the tip of the cigarette and inhaling it into the lungs. That's the way the nicotine is delivered to the body, but it's that delivery mechanism, the tar and the hot gases, that do the harm. We now have 4 broad categories of smoke-free, non-combustible tobacco. So there's a nicotine product. First of all, pure nicotine-based and heated aerosol. So these would be vaping products. There's a wide range of those, as you know. Tobacco-based heated products. These are heat not burn products or heated tobacco products. So these are things like the IQOS and BAT's Glow and things mainly made by the tobacco industry. Unheated products that are pure nicotine. So these would be things like the new pouches, sprays, films, lozenges, and a whole bunch of innovations that are coming out that are being essentially about delivering nicotine through the oral mucosa. And then finally, much more long-standing would be products like snus or smokeless tobacco, which again are put in the mouth or occasionally in the nose, but mainly the mouth. And the products are, and the nicotine is absorbed through the lips and the gum, the oral mucosa. Where do we draw confidence from that these products are much less harmful? Well, first of all, we have the physics and the chemistry. There are far fewer toxic chemicals in an e-cigarette aerosol than there are in cigarette smoke. The processes are much simpler. It's heating rather than burning, so you don't get uncontrolled combustion. You do get some pyrolysis sometimes, and that does cause some toxicants. But where we basically go for confidence in this is to biomarker studies. And this is a typical example of a biomarker study. I've chosen this one because it's quite visual rather than any other reason. So what you do is you list out potentially harmful chemicals in the blood, urine, saliva, the hair, whatever. You measure them and you look at the decrease that you get when somebody switches from smoking to, in this case, a Vuse product or to abstinence. And you can see the blue lines are abstinence, the orange and grey lines are vape products. You can see almost the same kind of declines in these biomarkers as you see for abstinence. I mean, they don't go down to 0, they don't go down to minus 100% because there are usually some residual exposures and also environmental exposures. In other words, exposures from other sources other than just the e-cig that they're using. The interesting difference is the nicotine one. You can see with the Vuse Vibe, this is the one on the right-hand side. The nicotine amount falls only a small amount. Whereas for abstinence, the nicotine falls to near 100%. So this is continued use of nicotine, but declining exposure to these toxicants listed along the top there. And there's a lot of these sort of studies around now. You put together all the evidence. You can use biomarker studies. There's been some major reviews of biomarker studies called the Royal College of Physicians, the National Academies of Science, Engineering and Medicine, and most recently in 2023 is the Office for Health Improvement and Disparities. Vaping poses only a small fraction of the risks of smoking. US study, far likely to be far less harmful, unlikely to, Royal College of Physicians, unlikely to exceed 5% of the risks associated with smoked tobacco products. Now, these should not be taken literally. These are approximate estimates. These are guidelines to try and give an understanding. This is another example of that. Again, not to be taken literally, but to be taken seriously. Here is someone who's done rough estimates of relative harm. They've expressed them to high levels of precision, 1 decimal place, which I don't think is appropriate. But the point that they're making here is this discontinuity that you see between the combustion products to the left of the chart and the non-combustion products to the right. And therein lies a harm reduction opportunity where the reductions in exposures, the reduction in estimated risk in this study are below at least 90% lower than they would be for cigarette smoking. Okay, and it's on that we rest the proposition of harm reduction. And then advice on this from the UK National Health Service. Also known as vapes, they are far less harmful than cigarettes and can help you quit smoking for good. So this is our National Health Service advice to smokers about e-cigarettes. This is what they publish. There's more information than this is, but the headlines. And then some appropriate caution. They're not recommended for non-smokers and cannot be sold to people under 18. All right, so fourth point now. These alternatives, some people worry that these alternatives just add to the total amount, just add to smoking, just make smoking easier. But we've got good evidence now from a variety of sources that these alternatives are displacing smoking and driving cigarettes out of the market. Okay, here's the UK data. You can see the recent rise of e-cigarettes, and if you plot the trend in cigarette smoking, you see an accelerated decline, sufficient to meet the UK target by 2030, which is a fight getting down to 5% smoking rate across men and women. Amazing studies, amazing scenes in New Zealand. This is the position in New Zealand. I just want to draw your attention to the red lines. So this is the trend in Maori smoking is the top line. You see much higher there, sort of around 30% in 2018, falling rapidly to around 15% in 2023-24. But at the same time, again, the steep red line going upwards, that's Maori vaping. Okay, now you could say that these curves may be unrelated, but I don't think that is even remotely plausible. I think the vaping is causing the accelerated decline in smoking. But that's just a statistical picture of what's happened in New Zealand. I think it's an amazing story, given how high the smoking rate is in that marginalized population, given how difficult it has been to promote smoking cessation, what a dramatic decline there's been in such a small number of years. This is Japan. This is a story about heated tobacco products. Independent researchers here, nothing to do with the industry. And you can see there that from around 2014, before the introduction of heated tobacco products, there was a gradual sort of trending down slowly, not great. After 2014, there's dramatic displacement of smoking by heated tobacco products, leading to a 50% reduction in per capita consumption of per capita e-cigarette sales. Okay, cigarette sales, that's the blue, and then per capita heated tobacco equivalents. So nicotine use has continued to trend down gradually, but the amount of smoking in the system has fallen dramatically, having been displaced by heated tobacco products. This is an amazing story from Norway. This is in young women, 16 to 24. And you can see here that smoking, that's the blue line, falls from 17% to 1% in 10 years. Okay, but what's happened is that snus use, which is a form of smokeless tobacco, has risen to 15%. So there is definite substitution here, but highly beneficial. Snus use carries almost no risk. It's very difficult to find any risks associated with snus use. Obviously controversial at the margins, but everybody has agreed that the use of snus is far less risky than the use of cigarettes. I want to just show you, to draw on the Swedish example to try and illustrate a really important point. So this is Sweden on a chart that shows smoking in blue and smokeless tobacco use in orange. Okay, and you can see that there's lowest level of smoking in Sweden, but quite high level of nicotine use through smokeless use. Now I want to compare that with Germany. That's Germany there. So you've got a lower level of nicotine use, but a much higher level of smoking. What do you think that will mean for lung cancer rates in Germany and Sweden, respectively? This is the picture. Okay. Roughly speaking, they've been coming down in both countries, which is good. But roughly speaking, Sweden has half the lung cancer rates of Germany. And we choose lung cancer because it's the most closely related disease associated with smoking compared to cardiovascular disease, which has a lot of different sources: blood pressure, diet, exercise, and so on. So that is an incredibly striking view of the difference between a country that makes high level use of low risk nicotine compared to one that makes a lower level use of high risk nicotine. Now, at this point, people will say, haha, what about oral cancer? And again, the picture is the same. I've plotted them at the same on the same chart axes. So you can see the levels of oral cancer mortality are much lower. But again, Sweden is about half the level of Germany. And the reason is that cigarettes cause oral cancer as well. Okay, so moving on now, young people will destroy smoking. Okay, now I always think about how to discuss young people in this, and this is a new way I've got of putting it. So see if you find this convincing or not. The very first thing to say is when you're thinking about youth vaping or youth pouch use or youth heated tobacco use, you've really got to consider a counterfactual. Okay, so there are two types of youth vaping: adolescents who, in the absence of vaping, would be smoking. Okay, so these are young people who are now vaping instead of smoking. Okay, it doesn't matter that they never smoked in the first place, but in a counterfactual world, without vaping, they would have gone on to be smokers. And then there's this group, the adolescents who would have never smoked, never used nicotine, never touched anything. Now, those are obviously the top group there. There's a significant benefit if they are vaping instead of smoking, as long as you accept that vaping is much less risky. The bottom group is that there is a small extra health penalty, which is associated with nicotine use that would have never happened, but nicotine use through a much safer type of product. South Africa, we are going to have quite a few of those young people who would otherwise have smoked. This is from the Tobacco Atlas entry on South Africa. You can see there we have men and women, roughly the same number as that we had in that WHO survey. So these are adults over 15, but concentrate on the children here. 10 to 14 years old, 21.3% of young men, 17.7% of young women, I mean, these are children, smoking, okay? Youth smoking prevalence in South Africa is 19.5%. So we can't ignore the counterfactual in which a large number of young people in the absence of vaping would take up smoking, okay? Because that's what they're already doing. That's what the default is. I want to go back to the United States now to demonstrate a couple of points. First of all, the red is the high school e-cigarette use, past 30-day use from 2011 to 2024. There was a major spike in 2019, but that climbed and then disappeared again, and levels are now back down to where they were in the early 2010. The rate of decline in smoking has actually increased slightly, okay, over that period. The blue is the smoking line. And we've actually seen in the United States smoking again accelerating in the post e-cigarette era, and is down now at very, very low levels indeed. And some of this, I have to say, has to be attributable to vaping. You know, young people are taking up vaping instead of taking up smoking. There's a comment, and you can see I've just put on the chart there the accelerated rates of decline. It's a great commentary from one of the sort of godfathers of tobacco control, Ken Warner of University of Michigan. The decrease in cigarette smoking among American youth is one of the great public health triumphs of the present century, yet few people are talking about it. Okay, and that has to be attributable in part to vaping, and I'll show why in a moment. Just a quick aside on the gateway effect. People worry about the gateway effect. There's been very good work done on this, but essentially there are two theories. There's a gateway effect in which someone smokes, someone vapes, and then that causes them to take up smoking. The better explanation is common liability, which is that whatever it is that causes them to smoke or vape also causes them to vape or smoke, and therefore the two behaviors tend to travel together in a certain kind of person that has the genetic and psychosocial characteristics that incline them to nicotine use. Population trends, ends of displacing cigarettes, and we've got to be careful that if we base policies on gateway effects that we don't end up with unintended consequences of increased cigarette smoking. I'm just going to show you quickly this because I don't want to run over time. This is, again, data from the United States. I'm sorry I don't have the equivalent for South Africa. I just couldn't find it and didn't have time to look any further. But this is by age group, okay? And the blue is vaping, the hashed is dual use, and the orange is smoking, okay? And light blue is vaping amongst people who've never smoked in the first place. There's two processes to understand here. First of all, people who are existing smokers are switching to vaping. So those blue lines, those blue bars push down on the orange as people switch from smoking to vaping. Those blue bars get longer and the orange bars get shorter. Then there's a second process, which I think is the really interesting one, which is that young people who never smoke in the first place or can switch to vaping at an early stage gradually age into the population. Okay, never having smoked and never ever being in the market for buying cigarettes. Okay, now, sorry, let me just go back one if I can. Just keep your eye on the left-hand bar there, the 18 to 24 years, because I want to show you something amazing that happened in that group. So that's that bar, 18 to 24-year-olds in 2023. And as you can see, there's quite a lot of people who have never smoked who are vaping. That's the light blue bar. And what I want to do is compare that with the situation as it was in 2014. Okay, so this is a sort of 9 years of 10 years of change has happened here. And you can see vaping was almost unknown in 2014, but now it's dominating, and there's been a 78% reduction in smoking and 87% reduction in exclusive smoking. Okay, people are not starting to smoke in the first place. They're going straight to vaping instead of smoking. And that is a radical change over a very short period. And it gives me confidence that in the end, youth vaping is an opportunity rather.
Sorry, Chair, but I think the speakers might have went on mute.
Okay, sorry. Can everyone hear me now?
Yes.
Yeah. Okay, thanks. Sorry. I don't know what happened there. Beg your pardon. Okay. All right. So they did not smoke before vaping. Is that a problem? No. It's not a problem because those are the population that would have been smoking instead. And that's why I say you have to take a counterfactual view of this. Right. Finally, on this section, adult welfare does matter to young people. We can't just separate the populations into young people and adults as if they are somehow unrelated. They are linked intimately through the family, whether a role modeling effect, secondhand exposure, household financial burden, and then ultimately caring burdens and grief and loss if parents die. Okay, so if you're only interested in the welfare of children, you have to look after the interests of adults. Right, I'm on my final section now. I'll go through this quickly. Two purposes of regulation. Consumer protection, trying to make the experience of using these products safe and reasonable as possible, and behavior change. Okay, behavior change is where you try and use regulation to stop somebody doing something or make them do something different. Okay, the problem with behavior change is it triggers a behavioral response in the users that may be different to the one that you actually want. So you get adverse behavioral change. So people will start smoking. You'll get illicit trade. So the supplier, the legal suppliers will exit and black market suppliers will come in. And then thirdly, workarounds. People will sort of mess around in their garage and try to make things that have been banned, like banned flavors, for example. Part of the South African legislation would ban characterizing flavors. So don't be surprised if you see some people returning to smoking, some people supplying flavored products via the black market, and some people making their own flavors in their garage or their kitchen. Okay, bans trigger unintended consequences. We know this from the war on drugs. We've had bans on cannabis, opioids, so on, and they don't work. Hello, sorry.
Hello. You've got 47 slides. We have done up to 47 slides now. We are left with 3 minutes. You should have noted.
I've nearly finished.
61,
I've nearly finished.
61.
Okay. I'm just saying there's good evidence that vape bans increase. I'm nearly at half an hour. I've got like 2 minutes left, I think. So there's good evidence that flavor bans cause additional smoking, and you can look at that in the thing. Bad regulation is the gateway to smoking. Illicit trade is already a major factor in South Africa. This is from the Centre of Research on the Economics of Excisable Products in Cape Town, showing that we already have around 60% of the cigarette market's black market. So using excessive regulation to try and stop vapes or try and you'll just have the same supply chains will be supplying black market e-cigarettes. The conditions for that have changed a lot. Containerization, social marketing, confidential channels, international payment systems, cryptocurrency, all facilitate that. There's already a market in workarounds that get around things like flavor restrictions. So my final point here is that what you should be aiming for is risk proportionate regulation, tough measures on cigarettes, and consumer protection measures on vaping, heated tobacco, and oral tobacco products. So high risk, high strength regulation, low risk, focus on consumer protection. Okay, this is my final point. This is how you deal with young people. I think keep the market lawful, risk proportionate regulation, age secure retailing, responsible marketing. All of these things you can do if the market is lawful. Right, and that's my final slide. Smoking is my penultimate slide. Smoking is the dominant problem. We've been through these 6 issues so far. More of this is written up on my evidence base, which is at that QR code. And then very finally on the bill, there are issues of concern that we can come back to. Some of the definitions I think are dangerous. An ad ban on smoke-free products will just protect the tobacco industry. Packaging warnings will frighten people off using safer products. Flavor ban will be counterproductive, causing more smoking, illicit trade and workarounds. Ends in health settings should be seen as an opportunity rather than a threat, and some of the penalties are extreme. And that's a QR code link to my consultation response. Everyone, thank you. I'm afraid I've gone a few seconds over time and apologize for that, but I'll stop now.
No, you were spot on your time. Thank you very much for that. And you now have a pen and paper
Yes.
for members to interact with your questions. They will all ask one after the other, and then you'll come up with a response. But however, the response will be very limited to the time that is allocated here. But I also request honorable members that presentations, how many people in the world are smoking and how many people are dying of smoke. So we have heard this question several times. The members will also be able to focus on the specific ones from Mr. Clive Bates and not maybe have 10 questions per member. Be mindful that we need to also go through some of them. Let me just recognize hands as they come up now. Honorable Motubase will be number 1. Honorable Dr. Carl will be number 2. Honorable Zungula, you are number 3. Honorable Dr. Litlape, you are number 4. Honorable members, just note your numbers. Honorable Sine, you are number 5. Honorable Kumalo, you are number 6. Honorable Mare, you are number 7.
And Honorable Msongo.
Honorable Chirampungose, you are number 8. And Honorable Msongo, we are number 9. Msongo. Okay. Honorable members, if you can just remember your number, I don't
You
come
miss
in.
me, Chair. My hand is up.
Oh my God.
Yes, Shabangu. Okay,
Yes,
sorry.
Chair.
Shabangu, you'll be number 10. Any
I'm
other
also
member?
on the line, Chair. Kleko is also on the line.
Peko, you'll come after Shabangu. Okay. All right. Let me then give members this opportunity to really remember their numbers so that I don't come in between. Number 1, Honorable Mutubase. Number 2, Honorable Dr. Leroux. 3, Honorable Zungula. 4, Honorable Dr. Litlape. 5, Honorable Sine. 6, Honorable Kumalo. 7, Honorable Mare. 8, Honorable Chirampungose. Number 9, Honorable Mhlongo. 10, Honorable Shabangu, and the last will be Honorable Peko. one after the other, honorable members, in that order. Let us try and not have more than 3 questions so that we can get all of us an opportunity. Thank you very much. Start.
No, thanks very much, Chair. And apology, I've just got out of the Sefako Makatu. No, George Mukari Hospital. But I'll give you the report. One question, my apology for coming late, and thanks very much. I've gone through the presentation in a written form. Just one question that I want to ask. What do you think, like you are talking about, I mean, this question that you raised at the last of regulation, and what do you think in the current form we don't have, and that should actually live up to what you are saying in terms of what is it that we are not doing that we should do best? And around this question of harm is harm, what is your understanding, and would you give us your perspective on the harm is harm movement by the department and many other professionals? Thanks.
Okay. Do you want me to respond to that now, or wait till we've had more questions?
I said get a pen and paper.
I've got it. I've got a pen and paper. I've written that down. Yeah. Okay. Okay.
Thank you very much for the presentation, and thank you for your insights. I just had 3 questions. I think the one is just I was struck about by that data looking at the US vaping in teens, and it would be interesting to see what they've done. I'd imagine there are different laws and different regulations in different areas of the US, but there was that big peak in 2019, which has come down significantly. Is there anything that we can learn from that? Then, in terms of the South African context, I think that one of the challenges for harm reduction approach is that partly, as you mentioned in your presentation, that the illicit trade is significant, and that cigarettes are very cheap, and a lot of the tobacco control that's been successful worldwide has been as a result of the price and excise taxes on and sin taxes on cigarettes, and so that's kind of made it more expensive and has driven people away from cigarettes to other options. Now, in our context, vaping seems to be something that is used by the well-off, and so what would you do? How does one shift that? Because there is, I mean, at the moment, vaping, even single-use vapes, are fairly expensive. So that harm reduction approach doesn't seem to be that easy to do in South Africa because of the price differential at the moment. And then the third question is just around being from the UK. You perhaps would have some data I didn't see in your presentation, but I know that there was a time when they tried to actually in the UK, NHS gave out vapes for pregnant women to try who were smoking and push them across. Has there been data following up those women, what the impact was of that public health? Thank you very much.
Okay. Yeah.
Thank you. I'll also keep it very brief from my side. In your first slide, you mentioned about people smoke for nicotine but die from the tar.
Yeah.
I think it's a very important intervention. Can you expand on that?
Yeah.
The second question is, currently the bill we are busy with takes a posture that all harm is harm. Now, from a scientific perspective, how does that contradict with the substitution of less harmful products? I think you can answer this in mind with the slide that you had about the USA, whereby the younger people are smoking less and engage more in less harmful products, whereas the people from age 75 upwards, they smoke more and engage less with less harmful products. And then the third question would be that the policy has unintended consequences. You spoke about that slide. What would be those consequences as per the current bill? Can you provide more details about ENDS in health settings? What does that look like in practical terms? Thank you.
All right. Chair, shall I have a go at these questions so far?
No, please. I made a request that you take a pen and paper.
All right.
And all members, 10 of them, are going to ask you questions.
Okay. All right. That's fine.
Okay.
So we'll get all the questions down, and then I'll try and answer them.
Yeah.
Okay.
Yes.
Fine.
Thank you, Clive. And good afternoon. It's Khosi Letlape here.
Hello. Hi.
Just 4 questions. One, what did you suggest in terms of access to alternatives in a poor resource setting because of the costs of the alternatives compared to the cost of cigarettes?
Yeah.
Secondly, the banning of disposables in Britain. How has that gone? And what is your suggestion in terms of youth uptake and environmental concerns, not just to disposable vapes, but the other alternatives?
Mm-hmm.
The last question is the notion of the products being available over the counter and medicalization of the problem and prescribing of the products. I mean, in Britain, the vapes are being given in the NHS. Should that be the route where we're looking at these alternatives on a therapeutic basis and they become prescribed? That's my last question. Thank you, Chair.
All right. That's number 4. Okay.
Thank you very much, Chairperson. Good afternoon, everyone in the platform. Chair, my first question. Honorable Chair, we are seeing worrying evidence that young people are increasingly being targeted and hooked on these products, and are often being targeted through flavors and packaging designed to appeal to them. So why shouldn't penalties for ends be as tough as cigarettes if they addict youth and carry long-term risks for users? And number 2, your arguments mirror industry's talking points. How do you distinguish your advocacy from interference under Article 5.3 of the WHO FCTC? Thank you, Chairperson.
Okay.
Thank you very much, Chair. Afternoon, colleagues and our officials that are on the platform. Chair, I'm just having a few remarks or questions that I want to put to Mr. Clive.
Yeah.
Mr. Clive, in your presentation, you did not say anything about other toxins in the products you are advocating for. And what is your take on the many flavors that are flooding the markets now? Please also unpack responsible marketing for me. And how will you target adults without marketing reaching the youth? For instance, the adverts running on the radio to promote vapes are basically targeting youth. And regarding age secure retailing, is the word secure and appropriate word to use, as we have learned about gaps or inefficiencies in this regard?
Yeah.
Can you also confidently say youth will not youth will not access online retailing unnoticed? Lastly, is there absolutely no combustion at all in these heated tobacco products? Thank you, Chairperson. That would be my remarks.
Yeah.
Thank you, Chairperson. I'm not sure if we're on number 8. But I'll
Seven.
continue.
It was supposed to be Honorable Mare, but if the president allows you, you can jump her. No, I'm joking.
Yes, you
She
can go ahead. You can go ahead.
Okay, thank you, Kombisa. I just lost track of the counting of the many people. Apologies about that. Greetings, colleagues, and everybody else. My name is Naldi Chirampongose from EFF, and these are my questions to the presenter in relation to marketing and advertising, right? In various countries, when tobacco and nicotine are being regulated, the first point of reference is usually advertising and marketing. And the reason why the assertion is that it does affect tobacco use is because even if you state that this advert or this marketing tool is targeted at people over the age of 18, for example, it doesn't mean that younger persons don't have access to it. In a magazine, on TV, and I think a previous speaker made mention of radios as well. So there's nothing overtly separating marketing tools on the basis of age, right? Through mainstream media and platforms.
Yes.
And that is a concern, right? That how do we make the distinction between a marketing for elderly people or people over the age of 18, and for that to be separated from young people, especially in the age of social media, of technology, of advancements made in that. And then second to that, even if restrictions and regulation doesn't necessarily stop smoking, it does have an impact on people who take it up. And there are various studies to this effect, right? Is it still a viable option if that is the result, despite all the cons that you mentioned and that are cited? But is it still not a worthy route to take, noting that even in the instance where it's a small portion, is that alone not victory enough to move in a certain direction for the nation, for nation building and working towards building a healthy community and society? Thank you so much.
Okay, thank you.
Thank you so much, Chairperson. Good day to all my colleagues and the presenter. Thank you for the presentation. I just want to find out, because I
Hello?
saying that it's very good to see that the vaping increase, because the children stop smoking. So I don't want to understand what is the difference when you say the person, because when you're vaping, you are smoking basically. Because like we are saying, the previous speaker was saying harm is harm. So I just need to understand is that everyone that comes on this platform is talking about the illicit trade that is so very high in South Africa. What are everyone that has been here, what are your research showing? Where is this illicit trade coming from? Because everyone knows that there's illicit trade and it's very high. Yeah. And then I also would like to understand is that the flavor ban. Everyone is talking about the vapes and the flavors, and everyone is talking about the cigarettes. But no one is talking about the hookah, whatever they name. They got these flavors, making children extremely violent, aggressive. And no one is talking about that. And that is also a flavor thing. And then I just would like to understand what measures will you put in place to ensure that these products that you're talking about, these vapes that you're talking about, is not expensive, because as you know, our unemployment rate is very high. And our teenagers is going through a lot. Teenage pregnancies, sex, all these things. Because somehow they must release their stresses. Somehow. What are you as a company or you as an organization saying about these vapes that is very expensive? Because the quicker way to do something is just by buying a cigarettes. And the cigarettes that is costing 10 rand, 15, 20 rand, compared to a vape that is costing 90 rand, 100 rand. I just need to understand that because you're saying in the first instance, you are saying smoke-free is better. But then you say vaping is not bad. I just need to understand that thing. Thank you so much, Chairperson.
Thank you.
Yeah. Honorable Mshongo.
Thanks a lot, Chairperson, and thank you for the presentation. It was well organized. So my question, the initial question that I was having was around pregnancy and vaping. So now it's covered. Then the last one revolves around the chemicals that can cause cancer and the chemicals that are known to cause lung disease when we are looking at the adverse events following vaping. So do we still need to push further on with vaping, or how are we going to assist our youth if they are encountering this problem? Thank you.
Yeah. Okay.
Thank you, Chairperson, and good afternoon to the colleagues. I've got a few questions, Mr. Clive. Thank you for your presentation.
Three, Honorable Shabangu, not more than three.
Okay, Chair.
Rules are three.
Yeah, Mr. Clive, you indicated that the e-cigarette, you presented e-cigarette as safer. Are you advocating for safety yet no one is precisely sure of what tomorrow holds?
Yes.
I'm sure you're well aware that there's no precise risk reduction figures as long-term evidence. Is like your response on that. And then you touch on the Japan, but you did not tell us that in Japan, the heated tobacco product use amongst youth has been increasing. Why did you skip that information? Why are you not telling us that Japan has banned all e-cigarette containing nicotine? Why did you not disclose that information? Are you do you recommend that we ban this product, this e-cigarette containing nicotine in South Africa? Because you can't pick and choose on the policies just because it suits your narrative. Why would this parliament not be concerned about nicotine, which is linked to cardiovascular diseases, which is a high-ranking disease which burdens our health institution in South Africa? What is your suggestion in relation to protecting the vulnerable groups, women and children in our proposed bill? Thank you, Chair.
Honorable Peko.
Thank you very much, Chairperson. Good evening to everyone connected to the platform. Let's appreciate the presence and the presentation of Mr. Clive. Just to check if the presenter is aware that in this country there has been e-cigarettes and vaping for the past 15 years. And that sector was not regulated. When he says they are introducing a safer alternative, does he understand the statistics that in the past 10 years, there's an increase both in vaping and smoking, especially among young persons? Also, I am interested in understanding why now, because there's a lot of them hard in advocating for these e-cigarettes. And that was not there before we introduced this bill. Why do we have, as South Africa, to take an alternative than regulating both the smoking and the use of e-cigarettes? I wanted to get answers on that, Chairperson. Also, if I'm not delaying you, will I be wrong to believe that the theory that the presenter is advocating for the use of these e-cigarettes as an alternative, which research also pointed out relapses, fails to recognize the perpetuation of addiction? Because even if you use e-cigarettes or you vape, there will be addiction at the end. I just wanted to check on that, Chair. Thank you very much.
Mr. Bates, I would have loved you to have mentioned that there's illicit trade problem in South Africa, like it other countries? I mean, because your statement there is like this is a unique problem of South Africa only.
That was not my intention. Let me just be clear about that. I had South African data and showed
we'll
it's a
get a
massive
chance
problem
to
in Australia.
Mr. Clive, we'll
Yes.
get a chance to respond to all your questions.
Okay, sorry.
And you'll be allocated only 10 minutes to respond. So those that you are not going to be able to touch base on, you will then have to write them to us. Honorable members, some of you have actually asked questions that I was thinking of in terms of this. So I would then allow him to reply at 4, Honorable Clive, you have finished your presentation and responses. Thank you. Those that will remain will then forward it to us in writing.
Okay.
Thanks.
Yes. Okay. Yes. There's a lot of questions there. Let me start with the big one, which is harm is harm, and that we shouldn't differentiate between different harms. I just think that's ridiculous. There is a huge difference between dying in agony of lung cancer or living in misery with COPD and having a sore throat. So we have to be clear that this is about harm reduction from very high levels of harm inflicted on millions of people to much lower levels of harm, not necessarily zero, inflicted on far fewer people. And therefore, we are trying to improve the total burden of non-communicable diseases associated with using nicotine products by switching from high-risk products to low-risk products. And there's absolutely nothing wrong with that. We do harm reduction in all kinds of fields, whether it's HIV, intravenous drug use, avoiding teenage pregnancy, and so on. And we do that because it works, but we don't do it with absolutist methods that say that you just cannot use or do these things. So it's a pragmatic public health approach to reduce the harms associated with using nicotine. I think I'm going to just pick up on a few things. So what do we do on regulation? I think there's a lot of things which are things not to do. And I think a lot of the ideas about bans or high taxes or limitations, the effect of those will be to trigger black markets. And we have seen this massively in Australia and in the United States, which are very strong regulatory bureaucracies. In Australia now, vaping products are available via pharmacies, sometimes via prescription, but less than 4% of people who vape in Australia use those pathways. The rest of it is supplied by criminal gangs, which are violent and incredibly ugly. The products are cheap, but they're also unregulated. Okay, so those criminal networks will supply any product to anybody, any illicit product to anybody. And if you want young people to come into contact with criminal networks and other illicit products such as harder drugs and so on, then having a large black market in vapes and, for that matter, cigarettes is one way to go about it, which I really do not recommend. The overall strategy has to be to meet legitimate adult demand for products that are much safer than smoking. And you don't do that through prohibitions. You do that through regulation that controls the marketing, controls the access, but make sure adults get the products they want. A lot of people in the questions said that this is all about marketing to youth. I don't think that's true. I'm afraid I don't have the exact numbers in South Africa. But if you look at the size of the youth market in any country and compare it to the size of the adult market, you will usually find that the adult market is at least 10 times larger. And that's because although there may be lower rates of prevalence, there are far more adults than there are young people of the age that are trying these things. So what most companies are doing are trying to market to adults, sometimes frivolously, sometimes irresponsibly. I grant that. But generally, they are trying to get hold of adults who have more purchasing power and have a much larger market for these products, and that's where they're actually competing. Okay, I'm just looking at the things that I've written down here. I think what I think things that were done well in the US, they introduced age restrictions, but I think as one of the questioners pointed out, you have to have some capacity there. You basically have to be able to monitor restrictions. You have to be able to hold retailers to account. But above all, the only time age restrictions work is when most of the market is legitimate and is being sold through normal retailers, not through the black market. So again, you always come back to how do you keep the market legal, and are there measures in the bill that will drive the market into illicit trade? Let me just look now. A good question on older smokers. There's more switching amongst younger groups, and that's true. I think it's true in most countries. It's difficult to get older people to switch, and they are more vulnerable to misinformation. So if you see scare stories in the press, or you see academics making out that vaping is more harmful than smoking, which you sometimes do see, incredibly irresponsible thing to do, but that's what some people do, then those people will be more reluctant. They're more settled in their habit. And if you just give them an excuse or a reason not to switch, then they'll do it. So dealing with older people is about having a much more tailored approach, like we have with our NHS advice, like you would have with physician advice. So somebody goes to the 50 or 60-year-old person, goes to the doctor, has been smoking for 4 decades or something. And the doctor should say to them, well, we've tried everything. You don't like anything we've tried. Why don't you try vaping? That will be a help to you if it works. So if they're getting advice from professionals, they're getting good advice from trusted sources, that's what will make the difference. There was a question about the UK scheme, which is sometimes called Swap to Stop. Generally, these schemes are targeted at low-income smokers or marginalized smokers, people who don't generally, will find it difficult to make the first step to switching to vaping because they'll have to spend money without being sure whether it will be worthwhile and don't have the ready cash in their pocket. So those schemes are always aimed at low income groups, and they're always framed as a sort of initiative to get you started. There are no schemes in which the National Health Service continues to fund vaping like a prescription medicine. It's an experiment to get people started, and the idea is that they fund the vaping from the savings that they would make on smoking, which I accept could be different in different countries. There was several people referred to the question, what do you do about people with lower incomes, and what's the harm reduction offer to them? Just in case anybody was mistaken, I do not belong to a company. I'm not representing commercial interests. This is a pragmatic public health harm reductionist point of view that I'm putting to you here. So I don't have any power over pricing or anything like that with any of the companies selling any products in South Africa. All I would say is look at the success in New Zealand. There we've seen the lowest income group, the most marginalized group, do extremely well through vaping, a rapid rise in vaping. So that group, and I accept that New Zealand Maori may be better off relative to poorer communities in South Africa, but that has worked well. But then I think the other thing to consider also is that there are other alternatives coming down the pipeline. There are, potential use for snus, a smokeless tobacco product, or now nicotine pouches, which should overall be much cheaper. But I think it is a good idea for the government and the parliament to put pressure on the manufacturers to have a low-cost entry point for vaping, snus, pouches, heated tobacco products, so that they are accessible. And at the moment that niche has been filled by cheap disposable products largely made in China. which are sold either legally or illegally in European countries or Australia and the United States. But that could be something that works as well. I agree that once you have a black market in cigarettes, the prices fall considerably, and therefore you risk locking in cigarette smoking because it becomes a low price habit rather than a highly taxed habit. But there's not much we can do about that for the time being. I think just steadily try to improve enforcement and try to get the market back into being legal. Somebody asked about whether I was speaking on behalf of the industry or I was making industry talking points. I really don't care. I'm so sick of hearing this. I am making points about public health with a logical public health argument that there are products that are much less risky than the dominant products in the market, which are the cigarette products sold by the tobacco industry. And if people switch to them because they're continuing to use nicotine, they will avoid a large amount of risk. And if that happens to be what the tobacco industry is saying, I just don't care, because that is how I see it from a public health point of view, and it's how you should see it too, from a responsible parliamentarian and governmental point of view. These products are an opportunity, not a threat. They are there to reduce the risk associated with ongoing nicotine use. There were several questions. Let me just, sorry, rifling through my papers. There were questions about, I'm just up at time now, but there were questions about nicotine use and youth. I think whether you like it or not, just as young people take up alcohol, take up caffeine, take up cannabis, take up other drugs, some of them will continue to use nicotine, and they will continue to use nicotine because they try it, because adults use it, and when they try it, they like it for the reasons that I gave in my section of the presentation about why nicotine use is likely to persist. Okay, the question is, if they do that, and I accept that you should do what you can to stop them, but if they do that, are they using products that are extremely dangerous, like cigarettes, or are they using much safer products like vapes or pouches? And if you can get towards the latter rather than the former, then the issue of nicotine use should diminish in public health terms, and we should have essentially a gain for public health, even amongst young people, because many young people, as I said, it's around just under 20% in the tobacco atlas of young people were smoking already in 2022. So there's a lot of gain to be made by having that kind of proportion of young people switching to vaping.
Okay, Mr. Bates, the rest of your questions, please write them back to us.
Okay, I will try to. I will try to make sense of what's written down and get back to you.
I will give you 1 more minute just to wrap up nicely.
Okay. All right. Well, first of all, thank you for having me to this hearing. I really do appreciate it. My final comment is, these products are a massive opportunity for public health. Nicotine use will persist, whether we like it or not. It's a phenomenon in society, like the use of drugs, like the use of alcohol, like the use of caffeine. If people switch from high risk to low risk products, we will see a reduced burden of cancer, cardiovascular disease, and respiratory illnesses. That may not decline to zero. There may be some residual harm, but the harms will be very much less, 1 to 2 orders of magnitude less. And that is a public health gain worth having. For those that say that people should just quit completely, I refer you to how poor the smoking cessation rates are for the established treatments. And the fact that you may want that to happen doesn't mean that it will happen. And you can see that because in South Africa, the smoking rate has declined slightly, but not very much, not been going up as far as I know. Okay, so you've got to be clear what you're comparing to. You're comparing to smoking cessation that doesn't work that well. You're comparing to young people taking up smoking, which is a bad thing. And once you make those comparisons, a harm reduction approach makes perfect sense. Chair, I will stop talking and shut up now.
Yeah, I gave you 1 minute. You took 2 minutes.
Did I? Oh, I'm sorry. Okay.
Okay. Thank you very much. You can stay so long. There are another presentations that are coming in now. Thank you very much. Your input will also follow you. Bring it to us. What is outstanding, together with this very presentation you made, will assist us as we wrap up and consolidate our comments as a portfolio committee on this bill.
I will write you a note that deals with the rest of the questions or all of the questions. Okay.
We'll appreciate that. Thank you.
But I'm afraid I can't stay for the rest of it. So I'm actually on holiday and I have to take my little girl out to the beach.
All right. No, enjoy your holiday. Thank you very much.
Thank you so much. Okay.
Yeah.
All right.
Okay. The next presentation will be made by a South African Non-Communicable Disease Alliance. And I want to start by upfront to say to this team of South African Non-Communicable Disease Alliance, next time if you get an opportunity to come to present to the portfolio committee, just follow these procedures. We get a presentation a day before. You don't get it on the same day. Okay, that is what actually members have been asking. Why are we not getting these presentations? And they are prepared to send to us. We normally receive presentations a day before. If a department comes to present to us and they bring along the presentation with them, we send them back until the next appointment. So we are very lenient. You probably didn't know the procedure. Presentations are brought to us a day before. Okay, we'll take you for 30 minutes. So at 4:45, you'd have finished your presentations, and then we can ask you to take a pen and paper, listen to the comments of the members, and then take their questions and reply accordingly. Now your 30 minutes starts now. Thank you.
Thank you very much, Dr. Shlomo. Sorry about not having sent the presentation a day before, so we really appreciate the opportunity. I will just start to share my slides quickly. Is that visible, Dr. Shlomo?
Yes, you can.
Okay, wonderful. Thank you so much. Yes, so I'm Pamela Naidu. I will be co-presenting with Elise Joubert. I'm from the Heart and Stroke Foundation South Africa, and Elise Joubert is from Cancer, but the Non-Communicable Diseases Alliance represents many organizations within the Non-Communicable Diseases cluster. And so thanks again for the opportunity to present at this parliamentary hearing. As you can see, our argument has been very systematically drawn up. So I deliberately show that, you know, we've really seriously thought through what we want to say today, because it's all really based on very strong evidence. Now, the South African Non-Communicable Diseases Alliance is a coalition of organizations committed to preventing and controlling non-communicable diseases in our country. It was founded in 2009 by the International Diabetes Federation, the World Heart Federation, UICC, and the Union. The NCD's Alliance began as a collective campaign for change. And the reason for that is we clearly have seen that there are common risk factors and common drivers in the non-communicable diseases space. And so we thought it's very important to mobilize together to make stronger advocacy presentations and policy change. So our mission is to advocate for policies and programs that reduce the burden of non-communicable diseases. Of course, it includes tobacco-related medical conditions. So again, to just reiterate, we represent a broad spectrum of stakeholders, including healthcare professionals, patient advocacy groups, and public health experts. And these are just some of the few organizations that belong in the cluster, including Diabetes SA. And so these are local and international alliances and organizations. Now, I think that to just dive straight into the scope of the problem, for us, it is a no-brainer because we have, as I said, more than enough evidence to show the harms of tobacco, and there's emerging evidence to show the harms of the electronic devices. Now, NCDs, such as cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes, are the leading causes of death in South Africa. NCDs account for approximately 2/3 of all deaths globally, and it is the leading cause of mortality worldwide, so it has to be taken seriously. In South Africa particularly, deaths due to major NCD has increased by 58.7% over the past 20 years, from 103,428 in 1997 to 164,205 in 2018. I mean, we're now in 2025. So, you know, if you do your math, there has not been a decrease. The economic impact of NCDs is substantial, placing a strain on our healthcare system and hindering economic productivity. Now, between 2006 and 2015, NCDs such as diabetes and strokes resulted in an estimated loss of $1 billion to the GDP. Tobacco is unfortunately a major risk factor for many of these medical conditions, and it contributes significantly to premature mortality and morbidity. Now, we've just got a little diagrammatic presentation of the effects of smoking on the body. You can see the illustration shows that it affects every organ in your body. So it is not only around cardiovascular disease and cancers, but many other non-communicable diseases as well, like mental health, like, sight issues. So your vision, for example, and other organs of the body, including bone density. It goes beyond the common argument that is made that, you know, it's often cited as the most burdenous cardiovascular disease and cancers. But if you take the cumulative risk for all the NCDs, it is pretty dire. Now, tobacco use leads to poor health and loss of productivity, you know, over and above the tangible medical difficulties. The use of tobacco products causes disease, disability, and death, and negatively impacts the health system, the economy, and the environment. Because if you look at tobacco smoking in the public spaces and indoors, including, the emerging evidence from vaping and other electronic devices, this does contribute also to environmental pollution. The use of nicotine products is also an associated risk for NCDs, as I've already said. The tobacco use is directly linked to over 15 different types of cancers, including lung and oral cancer. It triples the risk of heart disease, strokes, and other cardiovascular conditions. Tobacco use exacerbates respiratory illnesses such as chronic obstructive pulmonary disease. It is the leading cause of preventable death and disability. And the reason we say that is the leading cause is because it is behavioral at the end of the day. And we know that amongst the NCDs cluster, 80% of the deaths are preventable, and of course disability, because it's about the behavioral uptake of these types of unhealthy behaviors, like poor nutrition. Tobacco smoking is equally a poor behavior that can be actually, we could use primary and secondary preventive and health promotive measures. Hence, we're very strong on the tobacco bill. Sorry, I seem to be having let me just make sure that I'm on the right slide. Yes. So the health effects of tobacco products and ends continued, of course. I mean, it's just an illustration of the vaping device itself. It causes disruption in lung function, inflammation, oxidative stress, cardiovascular effects, impaired liver function, renal fibrosis, impaired immune function, affects reproductive health, affects periodontal health, and altered biochemical parameters. And we know this from the evidence as well, that decreasing tobacco use and vaping, definitely leads to a reverse in many of these, not totally if there's too much damage, but it certainly does improve the health outcomes of individuals. Now, the current landscape of tobacco control in South Africa. Existing legislation has had positive effects, no doubt, but gaps was put in place in 2011, and the tobacco control policy has remained quite stagnant ever since. It's been a long time. The emergence and the re-emergence of tobacco and nicotine products, such as electronic vapes,
Dr. Pamela, we seem to be getting you cut off. You are frozen. Mrs.
Yes,
Maybe
would you? I unfortunately won't be able to share because, let's see, Pamela. Let me try.
give a message to
Okay,
Beth
so
sharing rights.
I'll go ahead. I think let me continue. Also from my side, I just wish to also greet the committee, Dr. Clomo and committee, and thank you so much for the opportunity. So let me then continue. I think we were nearly done with this slide. As was said, that the emerge and re-emerge of the tobacco and nicotine products really poses new challenges. And recent data shows the rising prevalence of tobacco and nicotine use. And this indicates that the current measures are no longer.
Am I the only one who's got some black lines over the presentation? If so,
Chair.
You are not the only one, Chair.
Not
You
all
are
of
not the
us.
only one.
Not the only one, Chair.
I highly apologize. I don't know what this technical issue is, but is it so? Can I continue? Because is it unreadable, or may I not continue for time's sake?
just we can continue, but we'll see if it gets worse. Read.
Okay, I'm so sorry about this. So yeah, let's then go to the proposed tobacco bill. Really a critical step in the right way. First, measures proposed in this bill are evidence-based and will reduce exposure, initiation, access, and consumption of tobacco and e-cigarettes and promote quitting. And when consumption reduces, it means fewer people are using these products, which result in reduction in tobacco-related diseases and deaths and the unnecessary burden, of course, on the health system, and would result in a net gain in the health budget, just shifting the government's expenditure to other critical interventions within the public health sector, such as the implementation of NHI. Second, the bill will close the loopholes that have been exploited by the tobacco industry and e-cigarette companies in the existing law. The ban on smoking in public place and the use of electronic cigarettes in indoor and public places and certain outdoor spaces, according to a survey done in 2021, the SA Global Adult Tobacco Survey, the findings showed that 11.2% of adults who work indoors are exposed to secondhand smoke in enclosed areas at their workplace. 18% are exposed in their homes and 10.8% are exposed when visiting restaurants. The bill will protect non-smokers from dangers of secondhand smoke and aerosols from e-cigarettes. There's significant evidence in South Africa and globally to show that secondhand smoking or environmental tobacco smoking is as bad as directly smoking tobacco-related products. And the current 25% designated smoking areas in indoor public places are not effective since they expose workers in places such as restaurants to second-hand smoke and non-smokers alike. And the bill will therefore protect South Africans who are often involuntarily exposed to second-hand smoke, since no engineering system can keep smoke from drifting. And women and children bear the brunt of involuntary exposure due to difficulty of regulating within a domestic environment or other public spaces. And our Constitution of South Africa, Bill of Rights, accords everyone the right to an environment that is not harmful to their health or well-being. These are in addition to protection from second-hand related diseases such as coronary heart disease, stroke, lung cancer, breast cancer, and cardiovascular diseases. A complete ban on smoking and the use of e-cigarettes in indoor public places and certain outdoor spaces will protect the rights of all citizens to a healthy environment, and particularly infants and children who do not have a voice will be protected from diseases such as upper and lower respiratory tract infections, asthma, ear infection, and sudden infant death syndrome. Such a ban also promotes quitting and denormalizes smoking and vaping. Now, the existing Tobacco Control Act does not regulate electronic cigarettes and heated tobacco products. Emerging evidence shows that e-cigarettes are equally harmful and have been linked to health conditions such as lung and heart diseases, mouth ulcers, and also impacting the developing brain of adolescents. Therefore, if left unregulated, electronic cigarettes may worsen the already escalating tobacco use prevalence, also through nicotine addiction. And an additional concern about e-cigarettes is their popularity amongst young people due to how they have been glamorized by the e-cigarette companies. They are manufactured in fruity flavors to lure our young people. To ensure easy access by the youth, these companies have ramped up online advertising and marketing of these products and have created the so-called vape lounges around youth space. The devices are manufactured to sleek designs to enhance their attractiveness, and another tactic to lure young people to initiate e-cigarettes use. We believe regulating these products will protect young people from initiation and will further limit their access, thus reducing nicotine addiction in society. We therefore support the regulation of e-cigarettes and heated tobacco products to reduce their access, reduce attractiveness, initiation, also then to young people. Sorry, I just want to. Now, the current tobacco control law allows visibility of tobacco products at point of sale. Now, as a result, the tobacco industry has exploited this loophole in the law by increasingly advertising and promoting these harmful products. This industry tactic further exposes the population, but mainly young people, to tobacco products, thus increasing impulsive buying, which promotes initiation. Evidence shows that tobacco products displayed at point of sale influences youth smoking, promote the social acceptability of tobacco products, increase impulsive purchasing, and undermine quitting attempts. We therefore support a ban on the advertising and promotion of tobacco products and electronic cigarettes at points of sale. And that is, of course, in line with the World Health Organization's Framework Convention on Tobacco Control. Now, the current text-only health warnings on cigarette packages are not effective. Now, considering our health literacy gaps, we need visible health warnings to inform and educate all smokers and the general public about the harmfulness of tobacco products. Now, the survey I've referred to earlier has also found that only 35.6% of the current smokers thought about quitting because of the warning label. This insignificant number proves that the current health warnings on cigarette packs are ineffective. And for this reason, we support the changes proposed in the bill that plain packaging with graphic health warnings should be mandatory in all tobacco products, and e-cigarettes, and the font on packages should be increased. Plain packaging will make tobacco products and electronic cigarette packaging less attractive. This minimizes initiation and motivates users to quit. Plain packaging with graphic health warnings have been reported to be one of the most cost-effective and powerful ways to increase public awareness of serious health risks of tobacco use and reduce consumption. Now, the current Tobacco Control Act also allows sales of tobacco products in vending machines. Now, challenges experienced with this include that vending machines are places where young people can access them. They have no age restrictions and are used as advertising tools. A ban on the sale of tobacco products and e-cigarettes through vending machines will be effective in reducing illegal sale of these products to minors. By banning the source of tobacco products, we will reduce the number of young people taking up the use of these products and extend a supportive environment for smokers who are trying to quit. We are therefore in full support of the ban on vending machines that sell tobacco products, including e-cigarettes. Now, in conclusion, we as the NCD Alliance fully support the 2022 Tobacco Control Bill, as it will not only prevent youth uptake of tobacco and the use of electronic nicotine delivery systems, but it will also promote smoking cessation and prevent relapse for former smokers by removing sensory cues to smoking. We implore the committee to adopt it to protect South Africans, in particularly our children and the youth, as well as the health systems, and sustain our economy. The bill poses as an immediate measure that can provide substantial positive health outcomes in the short and medium and long term. Now, just to point out, we have given references, but we can, of course, it was also submitted with our initial submission. So with that, I thank you, and I am now open for questions. Thank you. I just want to
This is a delegation of mothers. Mothers are talking now.
Absolutely.
Yeah. So when mothers talk in a month of mothers, in a month of women, maybe there's a bit of listening that we need to do. Honorable members, let me recognize you. For those who want to engage with the presentation, I'll check your hands as they come up on the platform and then recognize you. There's the first one is that of Dr. Letlape. The second one is that of Honorable Sine. Number 3 is that of Honorable Kumalo. The fourth one, Honorable Zungula. Number 5, Honorable Shabangu. Full house. Number 6, Honorable Chirampungose. Okay, I'm writing as I Nicholas. And number 7, Honorable Mare. Number 8, Honorable Dr. Leroux. Anyone
And
who's left?
Mam Song.
Mam Songo, who is not able to raise her hand.
Yes, I can't.
She raises her voice. I hear that. Mam Songo.
Yes.
Anyone I'm leaving out?
You leaving me, Chair Kheko?
Mam Kheko, who is also not able to raise her hand, but her voice in the month
I did raise, sorry.
No, not a problem. In the following order, honorable members, one after the other, I don't have to come in between. The first one is Dr. Letlape, 2, Honorable Sine, 3, Honorable Kumalo, 4, Honorable Zungula, 5, Honorable Shabangu, 6, Honorable Chirampungose, 7, Honorable Mare, 8, Honorable Dr. Leroux, 9, Honorable Mhlongo, and last 10, Honorable Kheko. Mamu Chube, you will take a pen and paper, note all the comments that are going to come in now, and I hope the members are going to be conservative in their time. because we will then have to give you another 12 minutes after they've responded, after they've asked for you to respond. Start, Dr. Letlape.
Thank you, Chair, and thank you for the presentation. My first question is, there seems to be a lot of hope that the bill will promote quitting and youth not starting. Under our current legislative framework, we were shown a study by the WHO around 2013 that shows that the prevalence of smoking among our youth between 13 and 15 was about 20%. And that was in the absence of these new products that are generally available. When our pre-existing legislation and regulations could not reduce smoking, how is this tightening up going to improve that? The second question is, as people that see, as clinicians, the patients that you see that can't quit, what do you offer them? Because a lot is about people quitting, and we know the high relapse rate of cessation treatment. So for me, I just want to know what we're going to do about it. The last question is about the ban on public spaces. We've just had a 4-year-old buried today that lived in a one-room shack with an abusive father. When we ban from public spaces, are we improving safety to vulnerable communities? Are we taking into account our spatial organizations, just in terms of informal settlements where there's no space in between the houses and the ventilation inside is poor? Just applying these great novel plans to our reality. Thank you, Chair.
Thank you very much, Chairperson. Let me also appreciate the presentation. My first question, do you think the bill provides sufficient measures to protect the public and public health against fatal outcomes of smoking and vaping? Or perhaps the bill has additional provisions to enhance the protection measures in the interests of public health? Question number 2, there is a sufficient evidence that tobacco use causes poor health, loss of productivity, cancer, and premature death. Some argue that e-cigarettes are associated with the risk to cardiovascular disease. Do you think nicotine can cause health problems? If so, how best do you think these nicotine products should be regulated? Thank you, Chair.
Thank you very much, Chairperson. Let me also join the honorable members who have welcomed the presentation. But I'm just having only one question, Chair, to the presenters. Considering what the previous presenters claim to have learned, there has been talk of South Africa adopting the UK, New Zealand, and Swedish regulatory approaches. What is your comment on this? The UK has recently proposed a bill to impose stricter regulation on e-cigarettes. What are they proposing and why? Thank you, Chair.
Thank you and good afternoon. In your presentation, you alluded smoking and vaping are the same thing. Scientifically speaking, are you able to back up your claims to that assertion? And also, what do you make of the evidence that smoking releases 7,000 toxins and vapes and other non-combustible products do not? The following question is that what is the current problem with the existing Tobacco Products Act, according to your opinion? What have been its shortfalls if one takes account of the fact that smoking has gone up in South Africa since 2019 or so? And one assumes that the NCD Alliance was part of the process to update the country's strategic plan for the prevention and control of non-communicable diseases, which was adopted in 2022. Is the reason why the plan is silent on nicotine delivery system mechanisms, except combustible tobacco? And how do you think the illicit trade in tobacco has contributed to the rise of the smoking rate in South Africa, considering that it seems to have gone upwards at the same time that the country has seen an explosion in the rate of the illicit trade in the market? And lastly,
Oh,
in
no,
terms
no,
of
no, no,
vaping,
no, no. Honorable Zungula, no. That's your first question, number 5. Please, let's go to another member. You'll ask some other time. You are asking 5 questions. No. Let's go to the next member, who is Honorable Shabangu.
Thank you, Chairperson, and thank you for the presentation. We really appreciate. In relation to smoke-free laws, especially considering the restrictions on not smoking indoors, public spaces, and certain outdoor public spaces, in your opinion, do you think that those restrictions on smoke-free laws should apply to both traditional tobacco product and e-cigarette? Thank you, Chairperson.
Thank you, Sihlalo. Ngibulise futhi to the presenter as well. Thank you so much for your presentation. I think your presentation is sparking a very important conversation in the context of this portfolio committee by getting into women and children. Because, and I'm saying this because, you know, there's studies that are done in relation to how mental health and smoking are linked to as a coping mechanism, right? Where violent behavior can proceed or precede lack of access to smoking, right? Where, for instance, people with PTSD and depression smoke at very higher rates in comparison or in contrast to those who don't have these mental health debilitations. And lack of access to smoking tools otherwise manifest as aggression. And I think this is an important conversation in the context of South Africa in particular, noting our high levels of violent crimes and domestic violence and child abuse and young people, you know, being exposed to various mental health issues that lead them to addiction and sort of those things. Despite the fact that on the other side, quitting smoking can actually improve mental health and reduce such risk in the long term. And I would like to hear the deliberations of the presenter on this. On because we're in the portfolio committee of health, should maybe these conversations and these bills be accompanied by the strengthening of the mental health sector in the public sphere, for example? And yeah, I just want to hear the deliberations of the presenter on this particular item, since they made mention of these tangents, not directly, and maybe this is a digression, but I would really like to hear from the presenter in relation to this. Thank you so much, Slan.
Thank you so much, Chairperson, and thank you for the presentation. I just want to find out from you is that in households where the father or the mother is smoking, for example, to the children, how are we going to implement this? Because the parents will say, look, this is my house and I can do whatever I want to. That is just a major concern. And then I'm so happy to hear that you speak about the second-hand smoking that kills more people, like passive smoking. I asked the same question last week and no one has answered the question. Because you get people that have never smoked before, but because the partner is a heavy smoker, you lie in the same bed with the person and the person is smoking all over you. That person will get lung cancer and the other person will just be healthy. So I just want to understand. I want to say thank you for that. And I'm very happy to hear what you are saying, because I also believe that vapes is a problem. You know, vapes is harmful. Even though they say it is much better than smoking cigarettes, I still feel that harm is harm. And the problem that we are having is that more young people think it is it's nice, stylish to walk with a vape. I still feel this is affecting the children's brains because some of them are very young that start with this vaping. But I must say I'm very impressed with this debate, this discussion that we are having now, because I think this one is long overdue. Because everyone comes in and the only thing that they are worried about is how many money they're going to make at the end of the day. So I'm very happy with this presentation because I also feel that we need to discuss this thing when it comes to women and children. Thank you, Chairperson.
Thank you, Chairperson. Very much to the presenters and for your presentation. I think I share your sentiments around the questions about tobacco in public spaces, outdoor restaurants. I think those are very important measures that have been brought in, and I agree that there is evidence that those will decrease harm. I do find this concept of evidence-based measures that will decrease the smoking a little problematic, though, because I think that we've been presented with a huge variety of evidence here at this committee, and there seems to be clear evidence that pushing people, that very strict bans push people towards more harmful products, and so in the long term cause more harm. We've seen the evidence of the harm reduction approach in Sweden, which has resulted with clear evidence that there's much lower rates of cancer and non-communicable diseases in that country. So I think that I'd like to get your sense whether you think that there should be a differentiated approach and a harms reduction approach rather than the way that you bundled in your presentation everything together seems to indicate that you use a harms approach. So I wanted to get your sense about how do you regard the evidence around harm reduction and how those have public health benefits. I think, and then I think that I also was surprised that some of the harms that you mentioned, I have never around the e-cigarettes, not about kidney, renal fibrosis. If you could send those references to me, I'd really appreciate that. But that was part of the concerns was raised there. So I think that's my main concern is that I'd like to understand your take on the evidence that shows that there's a harm reduction benefit if we differentiate. Thank you very much.
Thanks for our presentation. Thanks, Chairperson. I would like to know, vaping is said that it causes some numerous negative impact on the body, affecting the lungs, the heart, the brain, and overall health. It can also lead to addiction, such as lung damage and lung inflammation and cardiovascular problems. As our health system has been overstretched and challenged by HIV, will South Africa be ready and be able to combat this challenge? It has been said that EVALI is a major lung inflammation and a lung condition that is not easy to be treated. So are we ready or are we armed professionally to face this challenge? Thank you.
Last, Honorable Kheko, thank you. Honorable Kheko. Okay. In the deep rural, she's not able to connect, maybe. There's been a presentation here from many other people, including what I am able to talk to now from WHO, of a phrase that says, if you don't smoke, don't start. If you do, please quit. But if you don't quit, change. Now, your presentation is not very strong in supporting, and I'm just picking on what Dr. Letlapa was saying, is not very strong in saying, what about those who are already in this swimming pool? You can't say to them, look, you just have to get out of it, rather than to modify and assist them somehow. There's another part where it says there are people who are actually arguing on a point that you are putting strongly somewhere on the bill to say, please don't ban our point of sale at least, but allow us to move these products a bit further than from where they are sitting next to the sweets and other things that are. So what you do say to those was the bill is talking about completely removing them from being visible to you, and they are saying they are very opportunistically visible next to the sweets and everything that is there for mothers to buy and children to remember, and maybe the young people to buy sweets and these products. You also, lastly, if you are able to comment about if look, you can't completely have no nicotine in the world. There will always be some nicotine. I don't know whether it is within your expertise to comment about the content and the amount of nicotine on any product that will probably be used. Thank you. I was not aware I'm locked. When did I get locked off? Which questions didn't hear? I now noticed that.
No, we could hear.
Oh, yeah,
We
so
could
okay. Honorable Kleko, are you back on the system? Not here. Okay, so we will skip Honorable Kleko now and get your responses. Please, we'll take you up to about 8 minutes after 5. Thanks.
Thank you. I think the first question was around how quitting, how are we going to assist young people quitting rates? Now, I firstly want to start, and I'll, my colleague will also give her opinions, but I've listened to the previous presenter saying that, around harm is harm, and that e-cigarettes will actually take people from a high risk to a low risk. But what we are seeing is that allowing and to encourage our youth to start using e-cigarettes and vaping is actually moving them to start initiating a low risk, and that usually then ends in a high risk because the dual use and making them nicotine addictive. And that is why we rather want to encourage our youth not to start and not even to start with the so-called low risk, because there are no low risks involved with e-cigarettes and vaping. So I don't know whether Pamela, do you want to react to quitting and youth, and that is why we appeal.
We will not finish, ma'am. Do your bit. Do your bit and then hand over when you are done with your bit. And then otherwise we are going to go to and fro and never make it. Do your bit and then complete, and then she will take over.
Yeah, so the nicotine in e-cigarettes is just highly addictive and particularly harmful to our youth. Developing and even pregnant women, developing fetuses, affecting brain development and increasing the likelihood of addiction to other drugs. And that is why we are, our presentation, I'm not going to repeat everything against this background. And we have actually found that the studies found that e-cigarettes leads to an impaired, so many other health damages. So I think, let me then go to the next one, which was how we are, let me see, do the bill provide sufficient measures or should we do more? I think in our presentation, we specifically, the bill do address loopholes. That's already there. We've addressed them in our presentation. And if I have to answer in one question, should a bill do more? To ban is easier to regulate. Now, this tobacco bill with the improvements, enhancements, actually just even more try to regulate And maybe if you want to ask my opinion on should we do more, I would go for a ban. But yeah, so the other question, do we think that the nicotine health products, that it will be better regulated? E-cigarettes, do we think it will? Yeah, I think the question I just have to read, do you think nicotine health products must be regulated? E-cigarettes, of course. As it's explained, that there are no lesser risks. There are just so many thousands of studies that and evidence that coming from studies that just show how harmful these products are, despite being marketed as safer or alternatives to traditional smoking. Yeah, there was then also a lot of questions about smoking and vaping. Does it back up claims that vaping is not so severe? I think we've dealt with that in our presentation, even though vaping products might not be as severe, it still exposes the user to very toxic chemicals, and as a link to serious health conditions, lung conditions, cardiovascular conditions, irreversible lung damage. So vaping is strongly associated with severe conditions that we should rather prevent. And nicotine in e-cigarettes is just as highly addictive and harmful to developing addiction. And that is why we are so concerned about our industry's tactics to lure our youth to vaping, hiding about or promoting it as a so-called more safer option, because it creates a youth addicted to nicotine, and that driving them to the higher risk to eventually start smoking tobacco products. Now, let me just see. I think shortfalls in the bill. I think it was asked in terms of yeah, I think the smoke-free. Let me just see. E-cigarettes, mental health. Yeah, with regard to mental health, I'm glad that this has been put on the table, because, yeah, we know that women are more likely than men to smoke as a way to cope with stress and anxiety and negative mood states, and it's often used, to deal with anxiety and depression. But unfortunately, tobacco is then have the side effect of heightened stress and anxiety during withdrawals, and greater vulnerability to relapse in women who try to quit. And women who smoke have significantly higher rates of mental health issues, like post-traumatic stress, depression, anxiety. So there's a strong association between anxiety disorders and tobacco use in women. And smoking can actually exacerbate mental health problems on the long term, and it provides just temporary relief. Heavy smoking is associated with better addictions. So yeah, smoking is notable higher and with mental health. So this is an issue that the close link to mental health challenges and both and smoking in women. And yeah, evidence shows that tobacco use is linked to an increase, yeah, as I said, but the smoking bans, especially in places, yeah, what they've seen in mental health facilities, has seen as an opportunity to implement evidence-based quitting strategies. Yeah, studies have also found that quitting smoking is associated with reductions in depression, anxiety, and stress. So that is why this whole issue, and why we have to focus more on cessation. I think there was also a question that I still want to answer, and then I will give my colleague an opportunity also to react. But the question was asked, what do we offer to cessation, and those who are already, and as you said, change, if you can't quit, then change. I think much more should be done in terms of educating and training our health professionals and our private healthcare workers in cessation, and to support those who want to quit. I think that I don't want to go into that. There's various strategies put on the and many studies have done, but we have to we recommend scaling up on the availability of support for smokers through training large numbers of health workers, including community health workers, to deliver brief cessation counseling. And it is shown in our trial works that we can combine that with SMS taxes and support. So we believe we must be much more effective in cessation counseling as we are currently doing. So I rather want to hand over to my colleague now to allow her also her 5 minutes. Thank you.
Thank you so much, Elise. Honorable Dr. Njlowa, I'm so sorry I got cut off, but I'm so glad I was able to reconnect gremlins in the system. So thanks, Elise, for coming through when I got cut off. So I will pick up on some of what Elise has addressed at a little bit of a deeper level. So I'm just going to maybe look at the questions that have not been directly responded to by Elise. I'm mindful of the time. But the NCD strategic plan, I got in to the discussion at that point. So I hope I heard it correctly. But, one has to remember the NCD strategic plan for South Africa, is really aligning with the WHO. So we should not see the National Department of Health being different from what the WHO is recommending. And the Framework Convention for Tobacco Control and its progress, since inception, it has been very clear. So much as the NCD strategic plan will focus, say, in this particular period on hypertension and diabetes, for example, as key drivers of other, non-communicable disease conditions as well. It also, I think, often ignored is the cumulative effect of risk. So if you have someone who's got cardiovascular disease, diabetes, cancers, and then still smoking, one can only imagine. There's more than enough evidence to show that tobacco smoking and vaping is a modifiable risk factor. So if I take that as one of the reasons why we are pushing towards, for this bill to be passed and to be adopted. Lots of the arguments that were presented have used Western countries as good examples of reduction or policies failing. Let's not talk about Sweden. Let's look at Africa. You've got a country, say, for example, like Egypt, where adopted the legislation and they have seen there's only a 5% prevalence. Then if you want to take a good Western example, you look at Australia. And this is going to bring me to the point about mental health and harm reduction, because the harm reduction is always being seen in relation to mental health issues. Now, mental health is not a siloed entity. Mental health is a cross-cutting issue. People with cardiovascular disease and cancers and diabetes and COPD can also be depressed and anxious. So therein lies the complexity. So let us not simplify this issue. You're going to be smoking, not because you're depressed, but it is a complex sort of scenario, because you have ill health, your productivity levels are low, your job is at risk, you're living in an inequitable society. Let us look at it more holistically and not ignore the fact that there are many components to why we are pushing for this bill to be passed. Now, if we use the argument of harm reduction, we're not saying it cannot be used in harm reduction, not at all. but then we need to put it in the right hands. We should be having mental health and other healthcare practitioners who help with the harm reduction practices. Like, you know, in Australia, for example, you have the vapes that are prescribed. You go to a pharmacy to collect them because that's been recommended as part of your harm reduction regimen. Now, if it is such a recognized harm reduction methodology, then I would imagine that SAPRA should be passing that as a harm reduction drug, like they do with other drug therapeutics. Okay, so I think we cannot ignore other bits of regulation if we want to utilize that as harm reduction and make that argument. And then in this very quickly, Chair, if you don't mind, I want to quickly address the household smoking regulation issue. I think it's a very important one. There's evidence, a study done in the Western Cape province by very, very renowned researchers. I mean, I can also share those, you know, we do, Elise, I'm not sure if you shared the reference list, but we can back up what we're saying as well. And what happened in that study was we went into, the key investigator, the key principal investigators, obviously, one of the key principal investigators is the renowned Dan Stein, and other investigators. And they found that even in unborn children, and this is where gender issues also come into play. This is now based on this really, really excellent study that was conducted. Even unborn children had traces of nicotine in their bloodstream. So yes, it is very difficult to control these and regulate this in the home environment, but it has to be legislated to protect children and women. Oftentimes, and maybe this scenario is slowly changing, but the pregnant women had no say, you know, if the males, for example, wanted to smoke indoors. So you had this cycle of inequitable kind of lifestyle. And then, you know, these are obviously communities who didn't have too many resources as well. And then they faced with their own internal sort of bias for ill health. So Chair, I'll stop there. But yes, you know, I just want to end by saying we do have the evidence and we're more than happy to share. Thank you so much.
Yeah, thank you very much. For any other outstanding comments that you did not bring to us from the questions, please do write to us, and we'll then incorporate that in our discussions going forward. Yeah, sure. So we think that you are strong on one side, but look, Elise was very thin on saying, do we allow cessation? No, there are people that you wish that they cease. They never cease. So we must provide something for them, because you can't leave them hanging. But anyway, let's not argue it further. You also brought some important points for our consideration. We thank you very much. We will be inviting another team now. You are free to stay if you wish to hear what they are saying, but you have really gained from your presentation. Thank you very much.
Thank you so much. Thank you.
Yeah. Our next presenter is what we call Free Kids something. Miss Machalamba, you'll guide me who's the next presenter. It's tobacco products. Okay, it's tobacco. Who's this one now? An opportunity to reduce harm burden. Okay, the next presenter who is going to introduce himself or herself, and then all I can say is that you do have 30 minutes from now on. So at about 11 minutes past 5, you start. So close to 22:06, you'd have stopped. No, you don't put your presentation this way. Rather go back to how it looked like before, not this way. It's now showing 2 slides in one.
Thank you, sir. Thank you, Chair. In the meantime, we're gonna start as we try to sort out the presentation here. Come on.
Do you see an icon on the bottom? That one that looks like an hourglass. Click that one. Yes. Click there.
Yeah, we're clicking, but it's not moving. Anyway, it's okay.
Then leave it as it is. Thank you.
Yeah.
Start.
Yes, thank you, Chair. My name is Zanele Mthembu. I am the country lead for South Africa under the campaign for tobacco-free kids. I am with my colleague, Advocate Patricia Lambert. Patricia and I have worked together for a long time in tobacco control in South Africa and beyond. We've also worked at the National Department of Health collectively and negotiated the FCTC on behalf of South Africa. And so, Chair, our presentation today, it's mainly centered on improving the health of South Africans, and we want to display how the bill is advancing that objective. And so as we start now, next slide, I do want to firstly just talk a bit about the campaign for tobacco-free kids. CTFK, that's our abbreviation, has been around for more than 25 years, working, prioritizing the low and middle income countries, working to reduce tobacco use and its deadly consequences. We mainly work collaboratively and cooperatively wherever we are and at a local level. And we support local expertise and locally driven evidence-based solutions. We are an organization that is accredited by the WHO FCTC Conference of the Parties. We've got that status. And if we look into our programs, what programs does CTFK work on? It's not only tobacco control. It's quite a handful. In addition to that, we focus on food and nutrition, health system strengthening, and injury prevention. We have as well our partners. We're not working alone. In Africa, we've got quite a range of partners, which include WHO, the African Capacity Building Foundation, an AU agency, and others as displayed on the screen. Now, in South Africa, we also have partners that we work with. Some of them is just presented, the NCD Alliance Cancer and Heart and Stroke Foundation, and the National Council Against Smoking, and so on, and the African Tobacco Industry Monitoring. Importantly to mention for us, we also have the MRC, because without advocacy that is not backed by research, then it's meaningless. And so it was important for us to get even the MRC as a partner. Now, in Africa, we have a footprint in quite a lot of countries, about 16 countries. I won't mention them, they are on the screen in the interest of time, Chair, if you allow. And then we also have, we are recognized in the African region by the AU. As you could see in the slide, we contributed technically to the development of a report on tobacco use on health and socioeconomic development in Africa, and under acknowledgements, the organization is acknowledged there. And now, Chair, we want to start by looking at the problem. What is the problem in South Africa? It's been the previous speakers, Pamela and Elise, they've already articulated some of this, the problem, particularly the data regarding the prevalence and so on. But we do want to say the prevalence in South Africa is on the increase. We're not doing that well. And another important point to raise here, which was raised last week by one of our researchers, is that the increase in e-cigarette, it's really, really bothering, simply because it's now the youth who had never smoked. We're seeing a 32% prevalence amongst them, those who have never smoked. And that is quite concerning, because if there's no regulation of these products, then it means we'll see this number escalating even more. Now, we worried about, again, the other piece of research we gained last week in this platform when the hearings were on, that the single sticks are mostly accessible to Black South Africans and mostly amongst young people. Now, again, this brings an issue of disparities, inequalities. Should we be allowing single sticks? If so, what should be happening? What level of regulation should be considered? And of course, the rest of the issues have been addressed, including people that are exposed involuntarily to secondhand smoke in the workplace, 11.2%, and at home, 18%. That has been addressed, the issue of at home. Now, again, this slide, we've seen it before in this platform during these hearings, the fact that the daily smoking prevalence in South Africa, South Africa holds the highest rate, about around 7% amongst all those countries. And that is really not good news unless something is done. Now, Honorable Chair, we're now moving to the substance of the matter. We're focusing now on the actual issues, the bill itself. So we're going to be focusing on three aspects. In the interest of time, we're going to be looking on three aspects: smoke-free environments, plain packaging, and regulation of new and emerging products. We'll try and not to rehash what has been said, particularly by the previous speakers. Now, we all know that the existing act, it allows smoking within 25% of the indoor public places. There's a problem with this. We've heard the problem being articulated, and the question is, should this continue? Because some of the presenters on this platform, they've advocated for the 25% designated smoking places to be left, to be continued and not to be tampered with. We hold a different view, particularly because the research that's existing, it informs us that there are no effective ventilation systems at present, and that's by the American Society of Heating and Refrigeration and Air Conditioning Engineers. But also studies that have been conducted in South Africa by our very own researchers, Professor Yusuf and others, indicate that when the pollution levels were tested in non-smoking areas, then it was detected that there's quite a lot of pollution in those areas, meaning the 25% is not working, either than exposing people involuntarily to harm, but what the bill sought to resolve, it's just not working. More people are exposed to danger. At this point in time, I'll hand over to my colleague, Patricia, who's going to talk now address the issue which we've heard again raised on this platform and others, whether smoke-free places are an infringement on the rights of the users of tobacco and nicotine products. Patricia? Okay, I can continue if she's not. Okay, let me continue in the interest of time.
Hang on.
Okay.
Hello? Can you hear me now?
Yes, yes.
Okay. Thank you very much, Zanele. And I want to put myself in context with my very deep greetings and gratitude to the Health Portfolio Committee for allowing us this platform. I am a constitutional lawyer by training, and I worked for 10 years from 1997 until 2007 as a legal advisor to the cabinet in justice and in public health. I turn now to this important question that we have heard many people tackle. Is it an infringement of rights for users of tobacco and nicotine products? The answer is emphatically no. No. From a constitutional perspective, the government has the obligation to protect the rights of everyone. And because smoke-free policies protect non-smokers and our young people, and they help people to quit, these rights need to be upheld. The right to health needs to be upheld by the South African government. And since no rights are absolute in terms of our constitution, they can be limited as long as there is a reasonable justification for that limitation. And you have heard those reasonable limitations in many of the presentations that you have heard so far. Next slide, please. So I have said that Section 36 of the Constitution provides government with the right to limit people's rights if they are reasonable and justifiable. Courts are consistently being asked to balance the so-called right to smoke with public health. But in fact, there is no right to smoke. There is no right to vape. There is no right to use any commercial product in our country. What we have is a right to be healthy and a government that needs to legislate in order to make that reality of public health real in the daily lives of people. A Korean court case, for example, found that if you hold in a judicial weight the disadvantage of smokers who cannot smoke wherever they like, and the advantages of protection for people who do not have to smell that or take it into their systems, the courts all over the world are finding that rights can be limited. I pass back to you, Zanele.
Thank you, Patricia. Now we're going to look at the next slide, which then talks to us. We ask the question, do smoke-free places harm the hospitality industry? Because we've had this issue being raised repeatedly in the previous hearings, now during these public parliamentary hearings. And of course, the evidence that we have does not support this view. In fact, what is coming up is that what the evidence shows is that in the short term, there could be, but in the long term, there's benefits to the hospitality industry. Why? Because people that previously did not attend, did not visit these places, they visit and they stay even longer. And we have the evidence from our own country as well, UCT, the RIP unit, Professor Corné van Velbeck, that's the studies that came out, but even in Seychelles, you can see that at the bottom of the slide, there's quite a lot of other countries that have where this evidence exists. Spain and so on, Caribbean and so on. In the interest of time, I would like to move forward. Now, another question that we want to address, should smoke-free places include e-cigarette? Chairperson, honorable members, we submit that yes, they should include e-cigarettes. It's important because remember in e-cigarettes, the vape is not just vape water. It contains nicotine, it contains those volatile organic compounds, it contains a whole lot of salt. But what's also, that comes from the WHO, the Empower Report of 2021. But also, the other concerning factor is that the manufacturers, in most cases, they do not disclose all the ingredients that are in these e-liquids. And again, that comes from the Empower Report of the WHO. We're concerned about renormalizing nicotine use. We know in this country, amongst the young people, the use of e-cigarettes is on the high and shockingly high, in fact. And that is concerning. And that is why we submit that e-cigarettes should be included in smoke-free environments. Now, we can borrow from the Cannabis Act that was signed into law in 2024. The Cannabis for Private Purpose Act, it already bans smoking and vaping of cannabis in public and certain private spaces. And this is exactly what the Tobacco Control Bill seeks to achieve, to ban the use of tobacco and related products in indoor and certain outdoor public places to protect the health of the nation. Of course, South Africa is not alone in this quest for smoke-free public places. We've got 9 countries in Africa as a whole that have gone this route. They are here on the slides, and in the interest of time, I won't enumerate them. And globally, 36%. And this means, therefore, that possibly the world, all of us were not doing well in terms of focus on smoke-free environments. And that is very important because of involuntary exposure. Patricia, over to you to address plain packaging.
Thank you very much, Sanele. So this is a weighty issue, and you will see that the next set of slides deals in some detail with: is plain packaging an infringement on the rights of industry to communicate with their customers? Should plain packaging be extended to nicotine products, and does plain packaging increase illicit trade? I will not read the slides to you. I will simply make the following points. South Africa already has rich case law on the subject of marketing and commercial speech. Tobacco product packs are used as a marketing device. The South African courts, the High Court, the Supreme Court of Appeal, and finally the Constitutional Court, all held in a series of decisions between 2011 and 2012, so not old at all, that the government had a right to curtail advertising and commercial speech about tobacco products. So that is sorted in our law. The next aspect would be Clause 5 of the bill does not make it mandatory to require plain or standardized package on e-cigarettes. Our proposal, however, is to make standardized or plain packaging mandatory for every single tobacco product as regulated in the draft new bill. And this is done on the same basis that the commercial speech is curtailed as upheld by the South African judicial system for the purposes of protecting, for the purposes of ensuring a high standard of health care. We can go on to the next slide and bring up the fact that, and I have heard this over and over again, that plain packaging will increase illicit trade. The fact is that that is not true. We do not know whether our bill will increase illicit trade because we haven't passed it yet. And when we look to other countries, it is very rare to find a direct correlation between plain packaging and illicit trade. The reason for this is whether it is a package of cigarettes the way the industry wants it, or whether it is a plain package with a pictorial health warning that will help illiterate or semi-literate people to know that this is a dangerous product, it doesn't make counterfeiting easier. And we have proof in South Africa from the Hawks and from the REAP project that illicit products in the South African market are undeclared local products. In other words, these are products made by legal manufacturers and put into the illicit trade ring in order to avoid paying tax. So this is not a public health issue. Illicit trade is an issue for policing. This bill is an issue of health, and the Portfolio Committee on Policing and on Safety and Security can handle illicit trade, not just in tobacco products, but in all products. You will see in the next two slides, and I am very mindful of time, you will see examples from Australia and from the United Kingdom of high-level court cases. The Australian case went all the way to the World Trade Organization, and in every instances, plain packaging of tobacco products was found to be allowable. And the plain packages were able to be marketed in those countries. I will leave you to read those quotations at your leisure. You will find they are very to the point. Next slide, please. And I hand back to Zanele for this.
And so now we look at what are South African studies telling us about plain packaging and graphic health warnings. We have a study that was conducted by a colleague that is at RIP in the University of Cape Town on the impact of plain packaging on quitting behavior. It was mentioned earlier, and it's always been mentioned, I think, that the issue of the use of tobacco and related product is a behavioral issue. So we'll have to look at the quitting behavior, and therefore, so this study, therefore, it shows that the plain pockets, they were perceived as to be less desirable than branded pockets, meaning if they're less desirable, therefore, people would not be keen to buy the products. And therefore, they are more effective in discouraging people from smoking. And this is our very own studies in South Africa. And this, by the way, it refutes the narrative that has been floating that South Africa doesn't have studies. We do have studies that have informed this very bill as we share every information that we gather with those that need it, including government. The second study looked at pictorial warnings, the impact of pictorial warnings, and is that they work. And it's not only in South Africa, they're very effective in deterring people from taking up these products. Now, we have to look at the regulation. The third aspect, as mentioned, that we want to focus on is the regulation of new and emerging products. And here, the key questions that we want to ask: what's the problem with the currently unregulated environment of those products? And what is the situation regarding harm reduction at present? And can these be regulated under one legislative framework? That is e-cigarettes, nicotine products, as well as conventional tobacco. Now, considering the problem, here is the biggest problem in South Africa. These products, the e-cigarettes, they are widely available and accessible to anybody and everybody. They are not only targeted, marketed, and promoted and advertised to those who are smokers who would otherwise use them should they wish to. Now, look at this picture. It's a picture that was taken on social media, a promotion that's a person, a young lady there, vaping. And of course, that really promotes, because other young people, as we know, the youth age, the young age is an age of experimentation. They'll follow suit. Now, the picture on my right, that is a picture of e-cigarettes, the vapes, and so many other things. This is a recent picture taken from Brakpan, one of the schools, a high school in Brakpan, and it was in the Citizen newspaper. Now, and this is the problem: the accessibility. Imagine such product found in class, in school. Then it means we are sitting on a time bomb as South Africa. Now, if we look at the definition of harm reduction, we are not, within the tobacco control community, we are not averse to harm reduction. But the problem that we have is the industry narrative, industry version of harm reduction. Harm reduction is a collation of policies and programs and practices that aim to minimize harm. And within that, you can never exclude regulating the industries themselves. And this also comes out from the UN Special Rapporteur on the rights to health and harm reduction, our very own Dr. Tlaleng Mofokeng there. And of course, as I indicated, that it's a combination of strategies. It's not just one strategy. And therefore, we submit that if the e-cigarettes and heated tobacco products and nicotine pouches and everything else within that has to be available, allowed in South Africa, we would need strict regulation. And these measures, these regulatory measures would need to be followed, because harm reduction is just not one approach. It's a combination of these measures. By the way, these are measures that are already advanced in this bill. Thank goodness, because heated tobacco and e-cigarettes are already taxed in this country. Now, can there be regulation under one legislative framework? Conventional products and the nicotine products? Yes, it can be done. That makes enforcement quite easy, because you can't expect on one hand the enforcement agencies to be looking for tobacco products, on the other hand, nicotine products. One law, it works. It's done in other countries. It can be done in South Africa. And by the way, the issue again of differentiation that we keep hearing, the question that what differentiation measures did government use to regulate, to propose these regulatory measures? We want to put forward that the bill, it does give differentiation. For instance, Clause 4 of the bill, it says the minister must prescribe standardized packaging and labeling of tobacco products. It must. And then Clause 5, which talks about now e-cigarettes, the minister may make regulation on labeling. Clause 6, the minister must make regulations as well on labeling of products that are used with e-liquids. Patricia, I see I took your slide, but anyway, over to you, Patricia.
Okay, let us go to the saturation of these products in the South African market. We cannot say that all of these products are not in our market, and because they are in our market and in increasing numbers, the onus is upon government to regulate them, because none of them is safe. Let's go to the next slide and talk for a couple of minutes about electronic nicotine delivery systems. Our bill would cover electronic nicotine delivery systems, but in its current drafting, it would not cover oral pouches of nicotine. Now, just imagine this, a pouch a little bigger than the first digit on your small finger. And you can tuck it in here under your top lip. What happens is that there are many blood vessels around your top lip. That is nicotine being directly absorbed into the human body, and nicotine is not harmless. And the danger here is that children as young as 10 have been found using these products because they are virtually undetectable. You can't see them, you can't smell them when they are being used, but they are being used. And so in addition to the regulations currently under the bill, we would suggest emphatically that that be extended to oral nicotine products. The next slide, the one in front of you now, has interesting information, but I'm going to ask you if you would go to slide 32, please, so that we can wrap this. There have been many legal victories in court systems all over the world, and we've listed non-African and African countries where these huge victories have been experienced. The courts are backing strict tobacco control in all of these countries, and we are victorious every time. Let us go to the next slide. And this is perhaps, in a way, one of the most important slides in our presentation. The reason being this: we are hearing that somehow the WHO FCTC is not binding in South Africa because it has not been domesticated in terms of international law. I would say that this is simply not true. It is not true. President Mbeki ratified the treaty in 2005, one of the earliest ratifiers. Subsequently, the South African government has acted in terms of that treaty by incorporating subject matter from the WHO FCTC into South Africa's domestic laws. For example, South Africa's domestic laws had the age for purchasing tobacco products at 16. The treaty has it at 18. So South Africa has already domesticated that clause within the FCTC into our domestic law. In addition, the law was changed in 2007 and 2008, again to incorporate provisions from the FCTC into our domestic law. And that is all that it takes to make sure that it is binding. And finally, if there were any doubt whatsoever, and I do not, as a constitutional lawyer, believe that that is so, if there were any doubt, look at the preamble of this bill, and you will see that it directly incorporates the WHO FCTC into South Africa's domestic legislation. I pass back to Zanele to conclude.
You only have time to do your last slide. Please you are done with time. Quickly deal with that one. Your time is up and we are still having one slide to do.
Yes, yeah. So, Chair, in conclusion, Chair, would like we submit that the law must be as future-proof as possible to protect the health of the nation, but also to avoid repeated amendments. We believe this bill is balanced and it can be enforced, and therefore we support it without exception. Thank you, Chair.
All right. This presentation is very close to Department of Health, as you had indicated initially, as you advise them now and then, here and there. First time I hear something that you are actually recognizing. The bill does not include oral nicotine pouches. It does not. And here you are motivating, rightly so, that if they are there in the country, they must be regulated. Now, it's something bizarre to have a product related to products and it's left out there. So you are actually commending that if you do find those, otherwise you are going to have a bill that is going to be completed into law, and then next year you say, no, bring it back to Parliament because we forgot to talk about oral pouches. It can't work like that. It can't. Thank you very much. Honorable members, can we then request your contributions, comments? I will start recognizing hands. The first one I recognize is that of Dr. Leroux. Dr. Leroux, we are number one, followed by welcome, Honorable Van Staden. We missed you. Van Staden, you are number two. Number three will be Dr. Letlape. Number four will be Honorable Zungula. Number five will be Honorable Sinme. Number six, Honorable Motubatsi. Who else am I leaving behind? Those are the hands. Any of the members of my committee that uses voices that and they shout and they don't raise hands? Let me wait for Mhlongo, for Keko. No. Okay. In this order, number one, Honorable Leroux, Dr. Leroux, number one. Number two, Honorable Van Staden. Number three, Honorable Dr. Letlape, three. Number four, Honorable Zungula 5, Honorable Sine, and number 6, Honorable Motubatse. Thank you.
I'm there, Chair. Taiko is there.
Okay, start.
Thank you, Chair, and thank you very much to the presenters. I found your approach interesting, and certainly you've brought some things to our attention that I think are very important, and also found the approach from a constitutional law perspective very helpful. So thank you for that. I think the issue about the nicotine pouches is important. So thank you for raising that with us, because that's would probably be something that we needed to look at regulating. The second question I have was, again, just around we spoke about, it was helpful to hear the perspective around restaurants and and also the research around restaurants, and how that doesn't seem to have a massive effect on the industry, although there are some concerns about the money invested in infrastructure to take away smoke, and so there is a cost associated with that for the industry. But I just wanted to get a sense from a constitutional perspective. I hear the issues around limiting spaces. I think there is the one challenge about the household space and the rights of somebody to smoke in their home, and so I'd like to understand that, because that is it's a private space that is quite challenging to regulate, and so it does feel to me that there is some overstepping in that space, and I'd like to get your perspective on that. I think the other question I had was around the plain packaging. Now, I know you say that that it's not we shouldn't be worrying about the illicit trade, but there is quite a strong argument that was made by groups from the industry that this will push more people into this trade, decrease our tax. And I think we do have to think of the consequences of that. So, what is your response to people from the tobacco industry, the legal tobacco industry, who say that this will make their packets much easier to counterfeit, and therefore make it much harder for them to legally do their work, and that they will lose sales, and therefore we will lose income to that. So those are my main questions. Thank you very much.
Thank you, Chairperson, and thank you for welcoming. And to all the colleagues, I'm just going to say all is well on this side. Thank you very much. Only two questions from my side. And thank you for the presenters for your presentation. Only two questions from my side. As I understand correctly, if you say that it's your point of view that the existing tobacco legislation is not sufficient, but don't you think the problem with the existing legislation is not the legislation itself, but rather the policing and the enforcement of the regulations thereof? And then my second question is, regarding the offences and penalties under clause 16 of the bill, do you think that South Africa has the necessary manpower to enforce this legislation? That's all for me. Thank you, Chairperson.
Thank you, Chair. And thanks for the presentation. My first question is about any studies about single sticks that are largely used by Black South Africans. Any studies about patterns of use? Any concerns about what's their daily use? So if they are now forced to buy packs, will they smoke more? Are they smoking less now? Do we have any of those studies before we have unintended consequences because of insufficient information? You speak about the right to curtail. Now, when you do plain packaging, you are not curtailing, you are abolishing. Can you speak to that issue? You say illicit trade is for the police, but in terms of the FCTC, it is not for the police. It is for everyone, including health. That is why they recommend a national coordinating mechanism, because of the multiple ministries that need to come around that. And I'd just like to have your comment on that. Now, on the issue of spaces, I've just been wondering, since it's so dangerous out there with the lingering smoke, should we not be advising non-smokers to stay home and be safe rather than go into this polluted environment? And where will people who smoke smoke? The Korean example that you spoke about, they said you can't smoke wherever you like. So where are they expected to smoke? And if that is not provided for, is that not negligence in terms of their rights? And I'm not saying there should be no control, but you can't throw people in the street if you are regulating. Those are my questions for now, Chair.
Okay.
Thank you. Greetings to CFTK and their colleagues. I'll start by making a comment to say I disagree with the assertion that this bill has got nothing to do with law enforcement, or illicit trade has got nothing to do with illicit trade has got nothing to do with the bill. Rather, it is a law enforcement issue. We've been part of this process for months, and the evidence presented does show the correlation between illicit trade and the dangers or the harm to public health, and how prevalent illicit trade is, especially on the context of burdening public health. I'll start by asking, because most of the previous presenters, I think one of the things they did when they first presented was to declare their conflict of interest, whether there is or there is no conflict of interest. So I would perhaps ask the organization the sources of funding, and has the organization received any funding from Bloomberg or Bill and Melinda Gates Foundation? And given how they've got a relationship with the Department of Health, can we expect objectivity in your inputs on the promotion of nicotine alternatives for tobacco control? The second question is, given your participation at the government delegation at NEDLAC, can you clarify the role of your organization in drafting the current bill? And lastly, based again on your advisory role to government, can you give us a sense of the cost of the bill to informal traders and tobacco farmers? Can you also share the results of the modeling that was done when the current measures were proposed, taking into account South Africa's unique socio-economic circumstances? And what extent would you ascribe South Africa's increase in smoking to illicit trade? Thank you.
Thank you, Chairperson. Chairperson, we have seen repeatedly that tobacco industry does not accept stronger regulations without a fight. They normally use every avenue to resist measures that protect public health. And globally, tobacco companies challenge nearly every tobacco control law. What are the most common legal arguments they raise, and how have the courts responded? And I also have a question, Chair, on smoke-free laws. Should the same smoke-free rules apply to e-cigarettes as to cigarettes? And also, how do we know that smoke-free laws don't harm the hospitality or tourism sector? Thank you, Chair.
Thanks very much, Chair, and thanks for the presentation. You spoke about, and you are positively supporting the question of plain packaging. Now, my question would be the argument that if you don't see what you are taking, and if regulations are put in place to enforce regulations, how will we enforce regulations on something that we don't know? We don't know what it contains. Don't you think that if we know what is contained and who is the producer of this particular product, then we will be able to know and to follow through to that particular individual. Is plain packaging not in itself against what the bill is trying to do, because the bill is trying to control but not to ban? Is plain packaging not a subtle banning in itself? And secondly, what is your view around the open and the closed e or vaping? What is your view in terms of the closed and the open vaping? And thirdly, I heard you are very strong on the minister must. Don't you think that is too strong a language to expose yourself, having had the relationship with the Department of Health itself? And are those not tones that actually want to direct society or influence this particular committee, given your relationship with the Bill Gates Foundation, with the Bloomberg Foundation, if there is any, that you want this bill to move into a particular direction? And lastly, what is your view around the participation of international influence of institutions such as those ones that I've mentioned throughout the world? Thanks, Chairperson.
Is it not my chair? Is it not my time?
It's
Can
your
I get
time.
in? Yes, thank you very much, Chair. Let me start by appreciating the presentation and also commend the presenters on how they have structured their presentation. This is amongst the presentations that I will revisit as an individual, because their presentation has answered some of the concerns that I have been having. Only two that I am to raise, Chair, in wanting to establish if this bill successful safeguard vulnerable groups like children. Is it what it is proposing enough according to the group? And also wanted to get their, though they have sponsored their view on the issue of oral nicotine pouches, because I had a concern when some people encourage it, saying there are no emissions out of it, but they have said enough about it. Chair, I think let me also thank them in advancing a point that some of the challenges regarding illicit trading are as a result of manufacturers and producers ending up in this illicit trading that is a challenge now by those that just want to bypass the issue of tax. Thank you to them for sponsoring that point. Thank you very much, Chairperson.
Thank you very much, Honorable Keko. I want to start from where you ended. In fact, I've been following this matter up, and I learned that probably some of the presenters who have come in here, the big industry, have come in and have actually said this bill is not going to fly because illicit trade is actually a big problem. And yet, it is actually what Advocate Lambert was saying, that these are legal manufacturers who then masquerade as illicit traders by night, and they put them into an illicit ring so that they could actually avoid paying tax. It's not so much about illicit coming in from outside the borders of our country. And this matter, I really want to Advocate Lambert to repeat for my own understanding and digest it properly, to say you point fingers at illicit trade, government sort it out, and yet it is the very same person who is actually benefiting and also abusing the system to be a manufacturer, a legal manufacturer by day and an illicit trader by night. Now, I've always thought I should raise this, that there's a bit of, when you go to a particular shop, you go and buy a product that is called no name. My understanding is that plain packaging is not equivalent to no name, but it is actually saying, you could actually enlighten me if that, to say there must still be the name of whatever that product is, but that plain packaging must not be glossy. And the young people were presenting that it must not be very attractive and having fancy and glossy colors to attract, but it must just be a plain package and give us a name, what it is. Then, to avoid this narrative, to say plain packaging means a no name, and therefore everybody mistakes that with an illicit thing that comes in and says, this is a cigarette. What is the name of this cigarette? You must have a name to that cigarette. So I am glad again that among other things you are raising is that if you do have nicotine pouches, there would still be expectation of regulations, and you are wanting to, a differentiation there is actually coming into that space. Please support us with your responses in this, and that we are not going to go beyond, by 6:15, you'd have stopped or you'll be stopping. Thank you very much.
Thank you, Chair. Thank you, honorable members. Patricia, do you want to start with the legal matters? Then I'll take over the policy issues. Thank you. Oh, okay. I see she's not there. Chair.
Hello, I am here. Can you hear me?
Yes, Patricia, can you start with legal matters and then I'll take over the policy issues? Okay.
Thank you, Zanele, and thank you, honorable members, for your questions. I would like to deal up front with the issue of conflicts of interest. I have none. I was employed by the Bloomberg Initiative on a full-time capacity working out of Washington, D.C. for 16 years. That does not relate to a conflict of interest. I have taken up the issue of presentation to the Portfolio Committee on the basis that I am a fully qualified tobacco control lawyer and a constitutional lawyer in South Africa. So I believe I have no conflicts of interest. The only interest I have is of the health of the public health of the South African people. I'd like to start by saying that legally, this bill cannot do everything. It cannot deal with people smoking in shacks. It cannot deal with children's relationships with their parents. It cannot deal with poverty, inequality, or illicit trade. These are things that have to be dealt with separately. I would implore the members of the Portfolio Committee to look at this bill as a bill that deals with public health. Because what this bill can do is protect people from harm. What this bill can do is reduce consumption and improve health. And what this bill can do is put South Africa firmly implementing the WHO FCTC, which has enormous strides across the world. With regard specifically to legal definitions and to particularly with looking at statistics around the illicit trade in tobacco products, I would like to put a picture into the minds of the honorable members of the Portfolio Committee. And that picture is of a fox in a hen house. We all know that foxes find hens delicious. So why would we put the fox inside the hen house and ask the fox how to regulate the hens?
It will not regulate them. It will eat them. And so asking the tobacco industry to supply data or statistics or anything else, we have to not simply trust that industry data, that particular fox. We have to present data that is objective and obtained from the best science, including medical science, health science, and social science. So from my perspective as a South African constitutional lawyer, I would say that this bill is to be supported and it will be able to do the job. I would like to raise one other point made by Comrade Letlape, and that is that the FCTC requires a national coordinating mechanism. That is absolutely true, and the onus rests upon government and upon the Department of Health, perhaps, as a convener to ensure that that coordination takes place. Whether that coordination takes place or not, this bill can absolutely move us towards protecting the health of South African people. I'll stop there, Zanele, and hand back to you.
Thank you, Patricia. I also want to address the issue of conflict of interest. I have no conflict of interest. I work here in South Africa. I am a South African. Earlier on in the presentation, I did tabulate our approach, CTFK, to our work, that we work with people in the country, which is why I was employed. I'm a South African. Now, there is no influence. The recommendations that CTFK makes, the recommendation that I have made also as a person when consulted by the department, those recommendations, they take them or they leave them. It's simply recommendations. So it's the same thing they do with everybody else out there that they consult, but we do bring them forward. So there's no conflict of interest whatsoever. Now, the issue, Honorable Letlape, the issue of why not advise smokers to rather, non-smokers to rather stay home, but why should they be confined to home? It wouldn't make sense, and that is why this bill, we feel this bill is balanced because it protects both the smokers, the non-smokers, but then it also, with the measures that are prescribed, enables the smokers, for instance, the issue of health warnings, which will prompt quitting, the issues around, of course, plain packaging. So it shouldn't be. It's the same thing that was raised last week. I think it's the Cancer Association that read that email whereby a non-smoker who lives in a multi-storied building was complaining of a neighbor who smokes at the balcony and the smoke seeps through to them. But the issues, why should your choices to use these products infringe on the right of others to breathe smoke-free air? That is the issue, and that's the issues of rights. It shouldn't be. The rights, they get limited where they begin to infringe on others' rights and on others' health, as the courts have ruled. The other question, should smoke-free laws apply to e-cigarettes? Yes, they should. We believe they should, simply because e-cigarettes, as we said, they do not only contain aerosol, they also contain nicotine and a whole range of other substances. But also what is bothering, those e-liquids, no one knows at present of the quantities that are there. And that is why if South Africa has to allow e-cigarettes and heated tobacco, they have to go through SAPRA scrutiny. They have to be regulated. They have to ensure that in public places, because the bill aims to protect the whole of society, in public places, there's regulation, health warnings are there, and all that. And Smoke-free laws, I think we've dealt with that. And of course, the issue of regulating disposables and non-disposables. The problem with disposables are cheaper. And if we are to limit access by young people, we have to ensure that these are regulated or these are banned altogether. But also, let's not forget that adults who want to continue using these products, the bill does not stop them. They continue using them, the sale continue, but everything has to happen within the confines of regulation. And the industry, by the way, it has to be regulated, as indicated that they are complicit to illicit trade. SARS, there are so many reports by SARS that implicate the industry in illicit trade, and therefore they can't claim to not being involved. We know there are reports from SARS in that regard. Now, and so we do recommend tight regulation. Enforcement, yes, there is enforcement. Now, the bill, there's a clause that strengthens enforcement, but it doesn't mean the current law is not being enforced. Now, that strengthening of enforcement, it talks to the inclusion. The clause has extended the enforcement agencies to include beyond the current environmental health practitioners, SAPs, to include border management, as entailed in the National Healthcare Act as amended. And so it aligns this bill in terms of enforcement, it aligns with the National Healthcare Act as amended. And as I say, enforcement has been extended, and we can't really say it won't happen. Enforcement, we don't know, but we do know that government is acting in good spirit, in goodwill, exercising goodwill in this regard, which is to protect the citizens of this nation. Chairperson, if there's anything else we haven't addressed, within a week's time, we'll submit in writing. Thank you, and thank you, honourable colleagues, honourable members.
Okay, thank you very much. You have called us all different names, comrades, colleagues, and we accept all that in the name of being sort of confused by us. But thank you very much for your presentation. If there are any of the issues that you have left out, we will welcome that in your written form. Honorable members, as I indicated when we started this meeting, we'll take a break because the fourth presenter was not able to move in earlier when the fifth presenter withdrew. So we'll reconvene, honorable members, at 7 o'clock. I hope, Ms. Machalamba, you'll find them even much earlier than 7 exactly. So by 7, they've already been given sharing rights, and then we can start. So let us not probably log off, honorable members, just remain logged in until 7 o'clock, then we can proceed. Thank you very much.
Recording stopped.
What did they say?
Honorable members, we will be starting in the next minute.
Recording in progress.
Okay. Yeah, honorable members, can we start? I will now hide my face so that this gadget I'm using will not interfere with the other one. Thanks.
Honorable members, I'm glad that the presenter has logged in and has also sent us a presentation. Let me start by just giving an advice to the presenter. When you do get a date next time to present to Parliament, you will have to send the presentation a day before. It will not be that up to midday we don't have a presentation from yourselves. And that is putting a committee in a very big of a challenge, because we would like to interact with the presentation and come in here for you to highlight things that we have already seen and read, and just to engage on a discussion. So next time you come and present to us, make sure your presentation is sent much earlier, a day before. We'll appreciate that. So we will give you 30 minutes to present. And after that presentation, honorable members logged into this platform will engage with you, and they will then take a pen and paper to listen to their comments and questions. You'll then come back to reply on those questions. So your 30 minutes starts now. Thank you very much.
Thank you so much. I appreciate the opportunity, and apologies for not having sent the presentation to you earlier. So just to introduce myself, my name is Ishak, my surname is Tate. I'm a specialist physician, and I am presenting on behalf of PASA. I also teach in health promotion, and so this work I'm able to speak from a broader perspective, but also from a visceral perspective of dealing with people in the community, as well as in clinical and hospital settings. So just to give a brief overview of what we're going to be speaking about, I have a slide just to introduce myself and some of my colleagues that have been involved in putting this presentation together. We will give a brief overview on our thoughts on the bill, and just to put it out there that we really think that this bill is very important for protecting the health for all people in South Africa. I'm going to be speaking to why vaping is harmful, both from a adult perspective as well as a youth perspective, why smoking in public spaces is harmful. And then there are just some thoughts that I'm going to share around some aspects of the bill with regards to the monitoring committee, as well as conflict of interest. So as I've introduced myself before, let me also introduce my colleagues who are on this call as well, and will be helping during the Q&A section. Dr. Siyabonga Dlamini, who is a program coordinator of the Masters in Public Health and Postgraduate Diploma in Public Health at the University of KwaZulu-Natal. as well as Professor Leslie London, who is the chair of public health medicine at UCT. And then also to say that we have no conflict of interest in making this presentation. All three of us are members of the PASA special interest group in health promotion. So our overall comment, so I want to say that this bill is a very progressive bill with quite a few elements, and I think that our colleagues that have spoken before us have highlighted a number of those aspects quite well. So I'm not going to be reiterating them. I mean, there were quite a few excellent comments that were made by them. To say that coming from someone or from a health promotion perspective, this bill addresses policy. And so there's really an opportunity for systemic change. Also to say that a few years ago, South Africa was actually at the forefront of tobacco control, and we actually received numerous international awards, one of which in the year 2000 was an award for outstanding leadership by a government ministry, and the award was the Luther Altieri Award, which was named after an American surgeon who connected the tobacco to lung cancer and other illnesses at the time. So the first point is that vaping is harmful for adults. There was a study conducted in 2022. It looked at electronic nicotine delivery systems, or we'll shorten that as ENDS. And just to say that, you know, initially when electronic nicotine delivery systems came out, it was marketed as a magic bullet to help people end smoking traditional cigarettes. That is what it was marketed at. And so this study looked at the interaction between electronic nicotine delivery systems and cigarette smoking. And the participants were adults older than the age of 18. What they did in the study was they surveyed over 21,000 people, of which 4,600 were either using electronic nicotine delivery systems or cigarettes or both. And some of the main findings in the study, if you look at this red shade of this pie graph, was that 58% of the participants were not only using electronic nicotine delivery systems, they were also smoking traditional cigarettes. So 58% were using dual methods of tobacco delivery. And then 21% tried to quit. So they actually took it on with the intention of quitting, but they failed. There were 14%, which is this green area over here, that managed to quit. But then there were 8% that were non-smokers and that were introduced to cigarette smoking via electronic nicotine delivery system. So unfortunately, this magic bullet that we were promised and was marketed did not work as what was intended to work. And it unfortunately was a failed experiment. It was a national experiment that had failed, where more people ended up using electronic nicotine delivery systems than quitting cigarettes altogether. Now, you know, we certainly may argue that there is potentially a role for ENDS to be made available on prescription as part of a structured smoking cessation program. And there is some evidence that I'm going to speak to later about that. But perhaps that is actually where we should be going. So, I mean, myself as a clinician, when I see someone and people come to me and they say, you know, I want to stop smoking, right? The only way that people ideally should be having any substance to quit smoking, because nicotine is quite addictive, should be as a scheduled drug that I would then prescribe, and the same should apply to the currently available prescription medication that we have with regards to nicotine and electronic nicotine delivery systems. But if we are not saying that, then we need to certainly be looking at a way of controlling usage of electronic nicotine delivery systems. The next point that I want to make is that vaping is harmful for youth. So in 2023, a self-administered electronic survey was conducted on over 25,000 learners from 52 schools across the country, mainly in urban areas. What they found was actually, it was shocking. 16.8% were currently vaping, and 37% had tried vaping in the past. So nearly half of school learners are experimenting with vaping. And what I can say to you, you know, having worked in the youth area for many years, there's been a visceral increase in the number of young people that are using substances. And we can see the evidence for this coming through in the study. What is also significant was that vaping use was more frequent than smoking traditional cigarettes, dagga, or hookah pipe. And also, you know, one would think that you know, the older kids might be more responsible. Actually, what was found in that study was that the higher the grade, the higher the odds of vaping. And also, you know, you might think that, well, you know, maybe it's the kids that can afford it. You know, they will be more likely to vape. There was actually no relation with regards to affluence. And then the other thing within the study that they found was that 40% of these young people, when they vaped, they actually vaped in the first hour of vaping. And that tells us that there's a significant nicotine addiction in this population. So, you know, and the question is why? Why are young people beginning to vape? And so they actually asked this question, and they found that social influence and curiosity might be the initial reasons, but it often gets quickly replaced by enjoyment, pleasure, emotional well-being, and nicotine addiction in continued adolescent vaping. And the reference for the study is available. So the question is, can legislation impact on vaping? And the answer is a resounding yes. And we can learn from other countries. So in Australia, they introduced kind of stricter vaping laws. And in fact, they said that vaping, these electronic vaping substances can only be made available on prescription from pharmacies. And on top of that, these vaping substances couldn't be flavored. So there had to be a plain substance. And they actually actually found quite significant results. They found that the rate of vaping within a relatively short period of time decreased from 17.5% to 14.6%. And heavy vaping, which is more than 100 vapes per day, from 5.8% down to 4.3% of adolescents. Also, at the same time, the rates of smoking cigarettes remained low, and it declined from 7.8% down to 6%. So it's, from this evidence, there's a possibility that this legislation might also reduce the rate of regular smoking as well. And so, you know, ideally, if ends could be a tool for end smoking, then the best practice would be actually that we disallow vaping completely and only allow it to be given on prescription. And for me as a clinician, that would be ideal. Otherwise, we have to look at tightly regulating vaping, and we hence support this bill. The next point that I'm going to be speaking to is about smoking in public smoke spaces, and specifically referring to secondhand smoke. So the WHO Global Adult Tobacco Survey in 2021 found that among South Africans, 11% of working adults are exposed to secondhand smoking at work. 18% of adults are exposed to secondhand smoking at home, and about half of these adults are non-smokers. And I just want to pause on this point, because in my clinical space, I often see patients and they have chronic obstructive airways disease, which is usually as a result of smoking. That is the commonest reason why I see in the Western Cape someone coming with COPD. And when I go into this and ask them, have you smoked? Have you ever smoked? And then the answer would be no. And it's only when I dig deeper into the history that it comes to light that this person was actually exposed to secondhand smoke. So, you know, we cannot understate the dangers of secondhand smoke. And of course, there are other exposures, most commonly in bars or shebeens, which is 14%, in schools, which was 3.6% in the survey, and in restaurants, which was in 2.6%, and on public transport, which was 1.7%. But the key thing to drive here is that, you know, there's a very big smoking exposure to people at home, and a lot of them are non-smokers, and they are being harmed as a result of being exposed to smoke. So the question is, why is secondhand smoke important to prevent? So the WHO reported on tobacco usage from the year 2000 to 2025 that, and it was an estimated that the exposure to secondhand smoke led to about 1.2 million deaths per year. Now that is a very significant number, and I just want to pause for a moment and just compare this to HIV deaths. Now, I remember doing HIV research in the 2000s, and then the death rate from HIV was about 2 million. Currently, because of ARVs being widespread, that death rate has now gone to about 600,000 per year. So currently, secondhand smoke kills twice as number of people as HIV. And also, secondhand smoke increases the risk of ischemic heart disease, stroke, type 2 diabetes, and lung cancer. And then there's a whole lot of other associations with ear infections, asthma, low respiratory tract infections, breast cancer, chronic obstructive airways disease. But the evidence was not as strong as the other things that I mentioned. And the question is this fair? Is this fair for someone if I have made a choice not to smoke, and now someone in my household has chosen to smoke, and I'm exposed to that, then I have to be related or at increased risk for all of these diseases. In South Africa, it is estimated that between 6,000 and 14,000 deaths per 100,000 of the population are attributable to secondhand smoke. So, the question is, where does the responsibility lie in terms of preventing these deaths? And then in a Cochrane review in 2016, it found that there was robust evidence that a legislative smoking ban leads to improved health outcomes through reduced admissions for acute coronary syndrome and reduced mortality from smoking-related diseases. So just to summarize what I said on secondhand smoke, first of all, it's common. There's limited regulation on it. It kills and causes morbidity, and there's a need for greater regulation. The next point that I'm going to be speaking about is on the monitoring committee. So these are just some points that, as we read through, we thought just to raise it at this forum for your consideration. So we have the monitoring committee, and this monitoring committee will be very important in terms of ensuring that the regulations are actually met. So we feel that the powers should be made clearer if it's to be effective. There are quite broad terms of reference, and we think that it should include monitoring and
Yes, you are frozen, Dr. Tayat. Or maybe it's just my challenge only.
Chair, also frozen for me.
Not alone, Chair.
Okay. Oh, thanks for that. Dr. Mohammed Dataya. Anyone who can assist you to continue on this slide of monitoring committee? Dr. Dlamini, continue, please.
Oh, perhaps we could try and share the presentation again. Sorry.
You are now having rights to share, Dr. Dlamini. Continue.
Thank you. I'm just downloading the presentation and getting ready to screen share.
Okay, I'm so sorry. My app just
like
okay. Let me carry on. So I'm going to ask if this happens again. I'm going to ask one of my colleagues on the call to just continue.
Dr. Dlamini has got the slide. All right. I thought you would use Dlamini's slides and your voice.
Oh, okay. Let's carry on, and we can see from there. Otherwise, Dr. Dlamini can carry on. Okay. So just to carry on. So the powers need to be clear. We need to consider resource allocation, and currently the National Department of Health is quite stretched. So we have to think about supplemental sources with regards to monitoring. And then also the bill should indicate to whom the committee reports, how often and how the reports will be used. We should be able to receive public submissions and the reports should be made public. We should also be considering enforcement and look at what is the link between the monitoring community as well as enforcement agents. And then another point to make here is with regards to monitoring would be to looking at implementing surveys such as the Global Adult Tobacco Survey and the Global Youth Tobacco Survey. So we need to consider what the mandate is of the monitoring committee. Then with regards to appointment of the monitoring committee, we need to consider strengthening the appointment process. So we have to consider potential member bias, for example, appointing people with conflict of interest, and we need to have additional protection to guard against conflict of interest. We have to look at what's the expertise of the people on the committee. We felt that perhaps the specificity of the expertise needs to be strengthened as well. So, for example, do people on the committee need to have a public health background, a legal background, a law enforcement background, and also members that are on the committee should not be having any links to the tobacco industry. And then also, how does one terminate membership? At the moment, it is one kind of party that is involved in that. And so we feel that the appointment and termination process should be separated. The same entity shouldn't be hiring and firing as part of good governance. And also, if there is wrongful termination, what is the appeals process in that? Then with regards to conflict of interest, so there's the framework of Convention for Tobacco Control, which makes it clear that in the setting of implementing the public health policies with respect to tobacco control, parties shall act to protect these policies from commercial and other vested interests of the tobacco industry in accordance with national law. So there's an obligation to protect the committee and the legislation from tobacco industry, and to ensure that efforts to protect tobacco control from commercial and other vested interests of tobacco industry are comprehensive and effective, as it is essential to avoid conflict of interest for government officials and employees. So the bill identifies in paragraph 13, it expects the monitoring committee to protect policies from the interests of the tobacco and the industries, but the bill is silent on conflict of interest in the lawmaking process. For example, in this regulatory process, there's no mandatory requirement for people making submissions to identify that they have support from tobacco industry, nor do we know if the portfolio committee requires such disclosure from its own members and how such conflicts of interest are managed. And then there's also other international law obligations. So under the International Covenant on Economic, Social and Cultural Rights, South Africa, which South Africa ratified in 2015, the state is obliged to ensure that Article 27, people are able to enjoy the benefits of science. And so General Comment 25 defines state obligations, which includes states should take measures to avoid the risk associated with the existence of conflict of interest by creating an environment in which actual or perceived conflicts of interest are adequately disclosed and regulated, especially those involving scientific researchers who give policy advice to policymakers and other public officials. So there's an obligation, for scientific researchers to also disclose if there's any conflict of interest. So just to end the point on conflict of interest is that there are many voices in this conversation with regards to the bill. And some actors we know are not in favor of this legislation. And Parliament has its first obligation to protect and ensure the well-being of the population. And I think about my patients, I think about my communities who are being kind of drawn into this vaping culture, who are being exposed to secondhand smoke, who need protection. And particularly the interests of children. I mean, there is robust evidence that is showing that our kids are becoming addicted to nicotine. And there's also evidence from elsewhere that shows that nicotine exposure can affect scholastic performance. And we hope that Parliament will do what is right. So to conclude, I want to say the following. Firstly, vaping is harmful for youth and adults, and it needs to be regulated. Secondly, we need tighter regulation on smoking in public spaces. Thirdly, we've made some suggestions on how to strengthen the monitoring committee, and that conflict of interest must be declared and kept out of the policy-making process. Finally, to say that this legislation is definitely needed, and we look forward to speedy implementation, and PASA and other organizations are happy to assist. Thank you so much for your time.
Okay, thank you very much. On your first point, it does seem like there's a belief that the committee or the bill talks about vaping as not to be regulated. The industry has come up to us to say, we are operating so haphazardly, please regulate us. I mean, one of the things this bill is there is this is a new product. This is a new space. We have always regulated tobacco, cigarettes, but these new things have come in and there's no regulation. So there will be, but shouldn't be that it's a matter of how it is going to be done, but it shouldn't really be we are going to do regulations because there was no thinking about that. Hence, honorable members, I see the first one will be that of Dr. Leroux. Okay. I need another hand, that of Honorable Motubatse. Number 2. Number 3 will be Honorable Kumalo. Number 4 will be Honorable Zungula. 5 is Honorable Dr. Tlape. And 6, Honorable Shabangu. Number 7, Honorable Mare. And number 8, Honorable Sine. Okay, any other member on the platform who's not able to raise a hand and want to shout? A name?
Thanks, Doc. I'm covered.
Meaning that you are not having a hand up. Thank you. All right.
Yes.
Honorable members, one after the other, while Dr. Mohammed will then take pen and paper and write down your comments to be supported in this order. First one is Dr. Leroux, second, Honorable Mutubatse, 3, Honorable Kumalo, 4, Honorable Zungula, 5, Honorable Dr. Letlape, 6, Honorable Shabangu, 7, Honorable Mare, and 8, Honorable Sinne. Thank you.
Thank you very much, Chair. Thank you, Dr. Tate, for your presentation. And thank you. I think we're all in agreement that there's great concern about the impact of vaping on young children under 18, and that it's a major concern that there's no form of regulation of that at the moment. And I think that that's one of the big things that this act this bill is addressing. And I think that I think it's an interesting question. So I guess my first question is really around the vaping. I mean, you make the statement under the slide of the looking at the study that telephonic study from South Africa, saying that you use that as an example of vaping being harmful. But I'd be interested to hear. I mean, you didn't really speak about much epidemiologic evidence, and I know that there isn't that much evidence available yet because it's a fairly new substance. But I would like to get a sense of your perspective. If vaping relative to what on its own, yes, we wouldn't want people to be using it, but if we compare it to smoking, it does seem to be quite a lot less harmful. What is your perspective on the relative harm of vaping versus smoking? Interestingly, that slide that you presented to us, I see that as quite a. Now, I agree with you that, and I think that sometimes we get put off by the fact that people have tried to, in their marketing, try to make vaping out to be this wonder thing. But and of course it isn't. And of course it's not going to solve all our problems in any way. But it does seem to have benefit. And there's a Cochrane review, which you didn't mention, but which isn't a huge number of people. But it also, in this study as well, it seems about 14% of people were able to use vaping to stop. And so and 58% were doing dual use, which probably means that some people who are smoking are using less. So from a public health perspective, and you're talking from the Public Health Organization Association of South Africa, it seems like there might be a public health benefit to diverting people from the more harmful smoking to the still harmful but less harmful vaping. And so I find it interesting. I interpret that table very differently to the way that you interpret it. I think that it's hopeful. The third thing I find interesting again, and perhaps as a public health practitioner, I have worked in the public health sector for years. I have never ever been able to refer a single patient to get a single patient onto nicotine replacement therapy or get them to a smoking cessationist. It's too difficult. It's too expensive. And it's a very elitist thing to say that every single person who I want to treat has to be prescribed by a doctor. So there does seem to, does seem to be some benefit. And on a big South Africa perspective, it feels like perhaps, and again, the evidence is still building, there might be some benefit of having less harmful things as a way to divert people from harmful products. And then finally, I think that Australia, again, we have been submitted with lots of evidence over the time, and people have used the example of Australia as a cautionary tale because of the reason, because as a result of their policies, a lot more people have been diverted to illegal, unregulated vapes. And so again, that wasn't mentioned, and I think that that's important to mention. And then we had New Zealand, who initially had a similar approach to Australia, who then moved to a less restrictive approach, and they seem to have had better figures with smoking and issues there. So I'd just like to get your comment on that. Thank you very much.
Thanks very much, Chair, and thanks for the presentation. You spoke about your views on conflict of interest. What is your view on people who have conflict of interest with international organizations or international companies? And what is your view also on the influence that international institutions and companies, especially that are within the industry itself, is there any contribution that you think that they can give, given their experience? But also you spoke about the constitution of the committee. Is it your view that people who are in transport, for example, they must have been drivers before they can say anything about the locomotive? Bring it back to this committee, because your views is that do you have a feel that this committee as it is now doesn't constitute relevant people with a relevant capacity that you can present to as we are now? The third issue that I want to get is on any evidence that can support your views around vaping. Is there any empirical evidence that you have conducted? And if you can, you can supply it to us, because I think you are having very misguided views, and the views that you are presenting with Australia, I think some of us have information that is quite dramatically opposite to what you are presenting. Can you give us empirical evidence? If you can submit it to the secretary so that we can go to it, that informs your views. Thanks.
Thank you.
Thank you very much, Chair.
Honorable Zungula. Honorable Zungula, you are number 4 on the list.
Chairperson, let me take this opportunity to welcome the presentation from Dr. Mohammed. I'm just having one question, Chairperson. Dr. Mohammed, what is it that you can suggest that we can use to protect our people, especially the youth, from initiation and perpetual addiction to nicotine? Do you think that the bill is addressing that adequately? That is my question, Chair. Thank you.
Thank you. My apologies for that. Dr. Mohammed, the survey you referred to, was it a clinical study? And what was the methodology used to collect the data? And how many respondents took part in the survey? The second question, your reference to the fight against HIV and AIDS was essentially harm reduction. There was promotion of abstinence, condomizing. We now have PrEP, and all of those things, they reduce the risk. So if harm reduction is a general public health policy, would you agree that the same needs to be applied with tobacco by availing less harmful products so that people can move from the more harmful products to the less harmful products? The last question is regarding the need for South African citizens to take charge, or to have committees of parliament reacting or responding to the needs of South African citizens when formulating laws. Therefore, do you not find it perhaps as something that is counter-progressive when the public policy discourse is going to be largely influenced by external bodies, which is your international or foreign funded NGOs, foreign individuals, and the voices of the people that will be most affected by that particular policy is somewhat ignored? Those are the questions I wanted to pose. Thank you.
Thank you, Chairperson. Let me also join my colleagues in appreciating the presentation. I have one question. What is your opinion on what we should consider doing and what we should not do?
Honorable Shabangu.
Yes,
you jumped Dr. Letlape. Dr. Letlape was next.
Women
It's okay,
first.
Chair, just allow her to finish. I'll follow her.
Okay. Thank you for considering women first, ladies first. Thank you. What is your opinion on what we should consider doing and what we should not do in strengthening cessation program in South Africa? More so that the new generation products are also positioned as quit or cessation tools. I would like to hear your response on that. Thank you, Honorable Chair. Thank you, Dr. Letlape.
Thank you, Chair, and thank you for the presentation. My first question is about the evidence for less harmfulness of non-combustible products. Are you aware of the FDA having looked at 3 product categories? Heat not burn, which was authorized for less harmful constituents, reduced exposure. Snus, which was authorized for a public health benefit. And vaping, which was also authorized for a public health benefit. And the fact that you have the NHS providing vapes on their public health system. The second question is about lack of comparing e-cigarettes to combustible cigarettes on the studies that you've shown. As has been alluded to, your first slide showed people quitting 13.9%, which is higher than the quit rates that we get from NRT. And we don't know what the health benefits are in the large group, which is more than 50% of dual users. The last question is, for your patients that can't quit, who have failed on the traditional methods, what do you recommend to them? And is the nicotine in NRT and patches and gums different from the nicotine that is in nicotine pouches or e-cigarettes? Thank you, Chair.
Honorable Mare, are you
Thank
there?
you, Chairperson. Thank you, Chairperson. I just have a comment, Chairperson. I don't have a question. Is that I am so happy to hear that people are talking about the second-hand smoke. I used to do nursing, and I could see my patients that had never smoked in their lives getting lung cancer. So this tonight, I must say tonight, all the discussions we had was very informative, and I want to say thank you for this discussion, Chairperson. Thank you.
Thank you, Chairperson. And let me also thank the Public Health Association of South Africa for your detailed presentation. I just have one question. Should this bill be passed as a law, what are the first priority actions for South Africa? According to you, what should be done immediately? Thank you, Chair.
Dr. Dataya, on the research that you put, vaping is harmful, but you are talking about 2 slides, vaping for youth and vaping for adults. Let's start on the vaping for adults. I don't know whether your results there are complete. They showed 4 areas. 1, those who had more than 50% dual use, 14% quitted, 21 failed, 8% were introduced into this. I would have thought there were those who also remained on the e-cigarettes alone. I don't know what happened. Not only those who were in dual, but you mean your study never had those who then became only e-cigarette users after that. It's related to what Dr. Letlap has asked, but mine is a different one. There's a category of citizens I would have thought they then never quitted, and some of them failed, which Dr. Letlap is asking, what happened to those who failed? Are there no other citizens there who then remained only on just e-cigarettes? Now, on vaping for youth, I would have thought, is your study, did you show whether it was a single-use type of a gadget or it was a multiple-use? Because there has been a thought that because you have to regulate vapes, you can't throw them away, they have to be there. If you then stick with the vapes that are multiple use, probably the higher brackets of a cost, then a high school boy or a girl would not be able to access that. So you probably might to that. But if you fail to regulate them through, what's this thing you suggested, pharmacy prescription, would there be no room for suggesting that the single-use vapes be banned, but allow this other type of vapes? Now, there's another, in your research, something that just confused me. 47% within the first hour. I don't know what, first hour of life or first hour of waking up, or what is that first hour? It didn't show. They vaped within the first hour, I don't know of what, in that space. So now, of course, if this is real, I need you to say it again, that if one is having unprotected sex exposed to HIV, you have half a chance of dying from that than if you were to die from being a secondary health smoker, or two times the chances of dying from a second-hand smoker than if you were to be on an unplanned pregnancy, on unplanned protected sex. That is probably what you are saying with that. You don't say it in that actual word, but looking at your figures, you are almost suggesting something like that. I'm not saying that's wrong. If you are figures, you are talking about 600,000. The other one is 1.2 million. So half of that is the other. Okay. It looks like I must have shocked you with what you said. You didn't say it that way. That go out there and be having unprotected sex because your chances of dying on that are less than those dying from. You didn't say that, but the figures that are showing are saying that, Dr. Ftaya. Come with your responses. Thank you.
Sure.
Or maybe you are going to give this to Dr. Leslie London. We haven't seen his face
No,
yet.
can I start? I'm just. Are you done? Are all the questions done?
We are done. We are done. Thanks.
Okay. Thank you so much. Thank you. Thank you for the engagement and these very interesting and fascinating questions. I just want to maybe just get the HIV story out of the way.
By 8:05, you should be done. 8:05. Thank you.
By 8:05. Okay. So I'm gonna let me make some comments, but let me give maybe space for Professor London and my colleague Dr. Siyabonga as well to say something as well. So so first of all, apologies if what I was saying was not that clear around HIV and the relation to HIV and this. So what I'm saying is that at the moment, if you look at the number of people in the world that's dying from secondhand smoke, it's 1.2 million. And at the moment, we have, because we have been able to put in place universal ARV access, our rate of dying from HIV has lessened significantly. And so, we're speaking about harms reduction. And the question is, well, aren't electronic devices a form of harms reduction? Well, if we relate it back to HIV and ARVs can only be given by a doctor. So it needs to be prescribed by a doctor or clinical nurse practitioner. So there's a clinical setting by which ARVs are given out. We don't, if someone acquires HIV, they can't just go to the pharmacist or go to their neighbor and get drugs and, start ARVs. No, there's a whole process in which the patient is clinically assessed. And after the clinical assessment is made, and you must remember that these substances, whether it's ARVs or whether it's NS, they have potential side effects. So we have to consider what's the risk of given this particular thing. And so I must say, Dr. Carl Leroux, I've been a great admirer of the work you've done in the rural Eastern Cape. So I think, you would be able to back me up when I say that when we speak about any intervention, we have to consider the benefits and the risks. And for us to kind of be widely dishing out something that is potentially harmful, I think as a government, as a health fraternity, that is not the most responsible thing to do. Any kind of intervention needs to be done with a particular plan. Now, I teach health promotion and I practice health promotion. We know that health promotion has many different components to it. And one of the questions was, with regards to the bill itself, what strategy does the bill place within terms with regards to reducing the nicotine addiction that we are seeing at the moment? So the bill is the policy aspect of health promotion, and it can have a big effect in terms of changing things. What it does, the policy does, is that it empowers behavior change on different levels. And so we will, and I teach my students, we'll have to look at how do we enact the bill at a institutional level. How do we enact it at a household level? And certainly what the bill does is that now for the poor patient of mine who had no recommendations, when her husband was saying, this is my house, I can smoke as much as I can, she can now report the husband and say, well, actually, what you're doing is illegal. So there is ways in which people can now be empowered through this bill itself. I'm going to actually stop at this point, and I'm going to allow my colleagues to speak as well.
Thank you, Dr. Dlomo and the committee. So I'll just respond to some of the questions. I think this argument about safe versus safer is important. It's not to say that we are saying that we are basing a risk assessment on the idea that they are equivalent. But the fact of the matter is that nicotine-based devices are not safe, and safer is not the same as safe. We can send a summary, a policy brief that was produced recently summarizing the different health effects, and the health effects are evolving, as Dr. Leroux points out. But I think from a public health point of view, we are interested in whether people end up addicted, and we're interested in whether people end up smoking. And the outcome is really important, because if your outcome is lifelong addiction to nicotine, you will have a different assessment to whether your outcome is whether somebody is off all tobacco products. And at the moment, the international consensus is that nicotine, as one of the most highly addictive substances, is not safe. Dr. Leroux is correct that access to treatment services are not easy in the public sector, and that is a problem for the service. And any intervention regulating vaping needs to be comprehensive, and that is a challenge for the health department, which we think has to be implemented. And under an NHI, it will be a problem, and certainly it will be a problem going forward. So we know that as a treatment it can work, but what we're saying is as a commercial product freely available in a mall, near a school, in a shop, it has potential harms on a population level, and that's quite clear. I understand the information from Australia, but it's also the case that smoking rates were increasing while vaping rates were increasing in Australia until the regulations were introduced. So that information can be critically reviewed. Can industry contribute? Of course it can, but it can't contribute within a policy space. And whatever structures are set up under the bill can receive expertise from industry, but industry shouldn't be allowed to make decisions or influence decisions that are in the interests of the public. I wasn't quite following the question around the expertise of the committee, which I think one of the members, honourable members, asked about the locomotive. But I think our point is that on the committee, you can't have decisions being made by this committee where people have interests that are, have an interest in the outcome of this committee's decision. There needs to be a sequestration of conflict of interest. In terms of foreign-funded NGOs dominating discourse, I'm not aware of foreign-funded NGOs dominating this discourse. The sources we cited were both South African and international studies. And if you call the World Health Organization an NGO, I don't know quite how we would deal with that because it is national governments from all countries, and if they give guidance, we consider that guidance measured. And I think some of the points made about, for instance, the National Health Service providing vapes is exactly what we're saying. It's being provided as part of treatment. It's not being provided as a commercial, unregulated entity, and we would support that. When it comes to quitting, again, we need to think about how that is sustained. So some of the studies you've probably seen are very short term and don't look in the long term at whether quit rates are sustained. And as for the 47% figure that Dr. Date quoted, it's within the first hour. That study also had other measures of dependence, which showed actually that the vaping users at schools in South Africa are quite highly dependent, and that's a serious problem. So I think in response to the last question about the first priority, I think it must be to protect children, because that is our constitutional obligation. In all matters affecting the child's best interest should come first. And this is the opportunity for the Portfolio Committee, I think, to realize that. I'll ask Dr. Dlomo if he wants to just, Dr. Dlamini, if he wants to just comment on the points that were raised in relation to his suggestions. Siyabonga?
Thank you, Prof, for that. And I also want to thank the committee for allowing us to make our submission. Perhaps maybe if I could start with the issue of harm reduction. I think in principle that approach has been proven to really have an effect on the population, especially on the topic that is at hand. We learned a lot from HIV and AIDS prevention and control. However, I think with that also comes the responsibility of ensuring that the contents of the products that are allowed to circulate in the population also, are not harmful to the populace. I hope we'd remember that it took years, a long time, decades, to establish that link between lung cancer and smoking. And the argument was therein was that there was no there was no evidence to suggest that smoking causes lung cancer, and yet that was established over a long period of time. And so exercising caution in our approach, I think it's the message that we are actually raising, and actually that's the approach that we're advocating for. That in the absence of that empirical evidence, because we understand that it will take a bit of time to to get to that point. In the meantime, let's exercise caution based on the historical evidence in other areas of prevention and control. I think that maybe with the issue of the committee, I think what we're concerned about there also is the issue of the legitimacy of the committee in terms of can the committee be seen to exercise its duties and functions in an objective manner, that and no undue influence is exerted on the committee because of the issues of conflict of interest and all that. And so I think with that is the kind of message and approach we are taking on that, to say that when it comes to issues of transparency, issues of conflict of interest, those issues should be at the forefront, so that whatever outcomes that the committee comes with, they are seen in a good light, and the issues around legitimacy are not questioned because of things that did not happen in a transparent manner, and so basically those are the issues that we wanted to raise. I think that's basically from my side I wanted to raise as well. Thank you.
Okay, thank you very much for your responses. They do assist us. Don't make it too difficult for the committee. We will regulate, but we cannot have people vaping. It's their constitutional right to vape for those, but you are correct. We need to protect young, especially youth and children, but still have other people accessing whatever they want to access in a regulatory manner. Thank you for your input, and we would consolidate our discussions, also supported by what you have presented to us. We will then call it a day, honorable members. Thank you, honorable members, and the staff that is supporting us. We'll be back on this platform on Thursday, the 21st at 3 o'clock again. Thank you very much. Have a good evening.
Thank you, Dr. Lomo.
Thank you, Chair.
Yes.
London.
Bye-bye.
Thank you, Chair.
Thank you.
Thank you. Bye.